All right, it's 9 o'clock. Joan, do you want to take a roll call first and see if we have everybody for the advisory committee? Now we have quorum.
Okay, Jessica Barlow.
Present. Good morning.
Good morning. Brittney Collins-Jefferson. Lilnetra Grady. Ryan Gustafson.
Yes, this is Ryan.
Dr. Kamyar.
Present.
Karissa Loper.
Here.
Katherine Loudon.
Good morning, Joan. I'm present. Thank you.
Elyse Monroy.
I'm here.
Darcy Patterson.
Present.
Pauline Salla.
Present.
David Sanchez.
Good morning, present.
Ariana Saunders.
Present.
Cornelius Sheehan.
Present.
Laura Sherwood. Dr. Wagner.
Here.
Quintella Winbush.
Yes.
And we've received word from Cecilia Maria and Laura Sherwood that they would be unable to attend today's meeting.
All right, thank you, Joan. Looks like we have quorum, and I'd like to call this meeting to order, and we will start with moving on to agenda item number 2. We'll open up for public comment number 1. Is there anybody available or interested in speaking as part of public comment number 1? Joan, do we see anything?
I do not. I don't see any hands raised.
Okay. Just gonna check attendees. I agree. Nothing open, no hands, no comments. All right, we will move forward, and we have a lot to cover today. So we're gonna possibly be reviewing, or we're definitely gonna be reviewing our recommendations and possibly approving them. But for now, we'll move to agenda item number 3, which is possible action to approve the minutes from April 20th meeting. In that meeting, we were introduced to the health equity lens presented by Tina Dortch from the Nevada Office of Minority Health and Equity. And we were provided with an equity lens to be used in our discussions and our decisions. Ms. Dortch taught us about choice points and provided worksheets for us to use at each major decision point. And Dr. Cantrell presented Mercer's needs assessment. We went through the gaps they identified and began developing recommendations. We heard from members of the public about gaps they saw and recommendations they wished for us to consider. Can I get a motion to approve the minutes from the April 20th meeting?
Jessica Barlow, I motion to approve them.
This
Do
is
we have-
Elyse. I'll second. Yeah.
Thank you. All right, we have approved the minutes from our last meeting.
You need to, we have to vote.
Oh, thank you. So now we'll take a vote. All in favor to approve the minutes from our last meeting, please say aye.
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 All opposed?
Aye.
Sorry. All opposed? Say nay.
David, this is Pauline. I'm going to abstain. I wasn't at the last meeting.
Okay. Thank you, Pauline.
This is Ariana. I'm also abstaining.
This is Brittney
Um,
Collins-Jefferson as well. I was not in the last meeting either. So I'm abstaining as well.
Okay. And I saw
Chair.
your, sorry, go ahead.
Sorry, it's Karissa.
I don't believe I was at the last meeting, so I'll renege my I and abstain as well.
Okay. And just as a reminder, the minutes are posted on our webpage from each meeting. I'm not sure if you guys got a chance to meet them, but that's why I gave a little rundown of what we talked about last meeting. So let's, I don't know if we need to start over or not, but to get an accurate count, I'm just going to go over it one more time. For those that were here, that were part of the meeting, last meeting, and are voting to approve the minutes, can I get one more aye?
Chair Sanchez, also, I'm noticing that people are stating their abstentions in chat. They need to vocalize their abstentions
Yes, ma'am.
in their
All right.
votes.
I will go through the cycle and make sure to include abstentions. So to approve our minutes from our last meeting, all in favor, one more time.
Aye.
Aye. Aye.
All opposed, do we have any nays? And any abstentions?
Aye. Abstain, I guess.
Yeah.
All right, thank you.
And me too. I also abstain. I was not at the meeting. Thank you.
Okay, thank you. I believe we have enough people in agreement to approve the minutes from last meeting. So let's move forward. And we will move on to a presentation to review the ACRN's purpose and responsibilities. And Dawn's going to present this. So just to note, the motion to approve the minutes has passed. Dawn, when you're ready.
Yeah, hi everybody. Let me just share my screen, and I'm actually going to stop my video so that I don't have any bandwidth issues. All right, can everybody see my screen?
Yes, yes, we can.
All right, good morning, Chair and members of the committee. My name is Dawn Yohe, and I am a clinical program planner for the Department of Health and Human Services. For this first presentation, I'm going to be giving today. We are going to be talking about concerns that we heard during the last meeting about this group not really understanding their purpose. And so since you guys have had really high-level presentations about the process and how this group is supposed to work, and a lot of pointing to SB 390, we decided to move forward today with a little bit more detail for you. So the Advisory Committee for a Resilient Nevada was established through the passage of Senate Bill 390 to be codified in the Nevada Revised Statute, excuse me, the Nevada Revised Statutes, NRS 433, by the 2021 Nevada Legislature to obtain advice and counsel from persons and entities who possess knowledge and experience related to the prevention of opioid misuse, opioid-related deaths, and injury, as well as the addiction and opioid use disorders within the state of Nevada. So the goal is to effectively address risks, impacts, and harms of the opioid crisis in the state through the Fund for a Resilient Nevada. We heard you last meeting when you said you were consistently told to go back to SB 390, but what does that actually mean? So these next few slides are going to break that down for you. There really are two goals for the ACRN to be able to develop and report, to be able to develop a report. This report then goes to the director of the department and is due on or before June 30th of each even numbered year. So starting with goal 1 of the ACRN, the statewide needs assessment including without limitation, the establishment of priorities as it relates to the information and analysis in A through D below. Priorities must include without limitation priorities related to the prevention of overdoses, addressing disparities in access to healthcare, and prevention of substance use among youth. And I know that you guys have really brought up prevention in youth and not being necessarily in the gaps, and really wanting to push a lot of recommendations towards that. So I'm not going to read through all of these, but they are here for you guys in this presentation for you to have afterwards. Goal 2 of the ACRN is to develop the recommendations pursuant to the statewide plan to allocate money from the fund. And so the department and the office shall consider the recommendations provided by you guys, provided by this committee, and they are also going to consider the recommendations of state, regional, local, and tribal governmental entities in this state whose work relates to opioid use disorders and other use disorders. So now we're at developing recommendations. When developing recommendations to be included in the report, the ACRN shall consider health equity and identifying relevant disparities among racial and ethnic populations, geographic regions, and special populations in this state, and the need to prevent overdoses, address disparities in access to healthcare, and prevent substance use among youth. At this point, this is how the health equity lens from the Office of Minority Health and Equity comes into play. This slide is about prioritizing the recommendations. So once the recommendations have been identified, they will be prioritized and rated using an objective method. An objective method will define the potential positive and negative health impacts of the affected communities with an emphasis on disproportionate impacts to any population targeted by the priority. Once recommendations are prioritized, they will be presented back to this committee at the June 8th, 2022 meeting within the draft report. The ACRN will then vote to approve the prioritized recommendations, or if there are any changes needed at that time, we will make the changes for you guys along with the draft report. So these are the next steps. June 8th, 2022, we will have a draft report for you guys to review. Mercer will be giving a presentation of the prioritized recommendations, and we'll walk you through how they were prioritized and rated. You guys can review them, and if you have discussion about that, we can have discussion and your approval. And then the draft report to the director will be up for discussion and possible action as well. Then on June 22nd, and I know that's really close together, it's only 2 weeks apart, we will have a final report for your review and possible action, and then we are going to be determining scheduling. So do you guys have any questions at this point?
This is Pauline. Can I ask a question, Chair?
Yes, please.
I put it in the chat, but is this a different presentation than the one that was sent to us? Is this additional?
This is like a precursor to what we're about to go over in agenda item number 5.
Thank you.
So in agenda item number 5, we're going to discuss, we're going to go over a presentation, and then we're going to discuss and review and possibly approve this group's recommendations. Any other questions?
Chair, this is Elyse. I don't have a question, but I just want to test my understanding of what I heard. Is that okay?
Please. Yeah.
Okay. So I think one of the
specific questions and where I think a couple of the committee members got stuck last meeting was like, what's the actual deliverable we were working towards? I don't remember who asked it, but like, what's the actual thing we need to create? So based on what I just heard, it's my understanding that we will be creating as a committee the document of recommendations, right?
Because we're on a limited time frame, what's going to happen is the state facilitation team, Dawn and Joan, are going to, whatever recommendations we approve, they're going to put together the report and then bring it back to us next meeting, which we will then edit or approve or deny, and then we'll move forward from there.
Okay, perfect. And then Mercer will use an objective measure to rank the recommendations by priority, but that objective measure is not the health equity lens that we saw last meeting, correct? And that might be a staff question. Yes, okay. All right,
Well,
thank
so
you.
if Dawn, you want to jump in, that's fine. But also I was going to say that, yes, the recommendations that we put forward will be put through Mercer's objective tool, and it is different than the presentation we had from Ms. Dortch last meeting.
Okay, thank you.
And Chair, may I?
Please.
Elyse, we're also going to be having Mercer come back and walk you through the tool so that you guys can see how the recommendations were ranked and prioritized, and you kind of understand, and that wraps back around.
Okay, thank you for the clarity.
Good questions. We're off to a good start. If we have no more questions about Dawn's presentation and review of what this group's purpose and responsibilities are, then I'd like to move us forward to agenda item number 5 for possible action. We'll have a presentation by Dawn, and then I'll jump in when we review the recommendations. We'll have a discussion, and we can vote to approve or edit the recommendations that we have so far. Dawn?
All right. I'm trying to share my other presentation. Bear with me just a second.
Thank you.
All right. Good morning again, Chair and members of the committee. My name is Dawn Yohe, for the record. Again, a clinical program planner for the Department of Health and Human Services. In this presentation, we are going to be going over the results of a survey that was completed by advisory committee members and recommendations for the report to the director of the department. The first couple slides are just a review for you guys to have in one place of who you are, what the goals of the ACRN are, how we are developing the recommendations. And then the goal of the survey was to assist the ACRN in this committee in prioritizing the gaps that we have in the needs assessment, and then identifying or developing the recommendations based on those gaps. And if you're somebody that hasn't been able to complete the survey, please let me know. I can always reopen it for you. So first, we're just going to be doing a high-level gaps review. These are the gaps that were identified in the needs assessment. We're not going to read through every single slide because we have a lot of recommendations that we have to get through today, but you will have them for review in this presentation. So first, we have data, prevention, general treatment, outpatient treatment, withdrawal management, inpatient and residential services, discharge and recovery support, harm reduction, social determinants of health. And then these are additional gaps that were identified through the survey from the members. We're going to make sure that all of these gaps are listed in the areas above. So these include public education to include all Nevada school district students. Youth and pregnant individuals should also be included. Prevention, secondary and tertiary strategies, data gaps, analysis, dissemination, feedback loops, and sharing. Recovery is long-term, and so helping those in our communities along the continuum of care with resources that are not just grant funded. Family support tools and options, education for educators, families, outpatient care, permission to work on harm reduction more closely to prevent deaths and overdoses, housing, treatment providers are needed in rural areas, victim compensation, family-based treatments and prevention, coordination of resources and detox centers in rural Nevada. So now I'm going to go ahead and hand this over to the chair for the recommendations review, discussion, and potentially approval.
Thank you, Dawn. So far we've gone over the gaps that were identified for data, prevention, treatment, outpatient services, like Dawn just mentioned. The survey that we all took noted the gaps and the gaps that were important to this committee. Now we're going to go over what we have identified so far as our recommendations. And during this time, I'd just like us to keep in mind that we were assigned to or chosen for this committee because we have experience where the I just lost the word, the experts in what it looks like to serve this community or be a part of this community that we're trying to advocate for. So on your screen, you have recommendations from ACRN, and this is the first page. On this page, what I'd like to do is I'd like to go page by page and basically put it to a vote of whether or not there's anything on, and we can discuss this, anything on each page that we need to change, take out, edit the verbiage, or if we want to approve, again, page by page, these recommendations that will move forward. And again, these recommendations as they are on page by page are not categorized, but we want to move them as part of this committee's recommendations to the director. And then we'll have Dawn and Joan and their team put together the report and bring it back to us once these recommendations have gone through Mercer's objective tool. So now's the time for discussion, and after discussion we will take a vote to determine if we are in agreement that page 1 of this recommendations are good to approve and move forward. Dr. Wagner, I see you have your hand up.
Hi, thanks, Karla Wagner. My question is, when I look at these recommendations, some of them are actionable things that you could put a chunk of money towards. Some of them are not. Some of them are like if we look just at this list, like mandatory prevention training. So are we imagining, is our recommendation to mandate prevention training and somehow tell schools they must do? Or is the recommendation to create funding that would allow for the implementation of prevention training? I'm struggling sometimes to align the kind of verbs here, like to
Yeah.
whom is the recommendation and what is the recommendation? And some, you know, like all of the above, yes, but you know, so I don't feel good about, or I'm not sure how I would vote on this page and just give it an up or down vote at this point. But maybe
Yeah.
I'm missing the process.
No, that makes complete sense. And you'll see as we move further, we're going to come up against the same thing over and again, especially when it comes to public comment and their recommendations. We have statements rather than actionable recommendations from us. And I think what we need to keep in mind is that we're a part of the total whole of recommendations that the state will review. And these recommendations will be, again, ran through the objective tool through Mercer and then prioritized, which again, there's been a lot of confusion and a lot of questions around what that looks like. You know, if it's this committee's feeling that, let's just start with the top one, mandatory prevention training in all schools is the #1 priority, it may not come out as the #1 priority once we put it through the objective tool. However, we have an opportunity to kind of denote that that is our #1, even if it doesn't come out in the Mercer objective tool as priority 1, but we can denote that this is an important recommendation for us. And again, this is going to, when we come across the verbiage issues, right, it's not an actionable recommendation. This is going to go into a report, which then is going to come back to us, and either we're going to approve it or change it or deny it, and then it's going to go to the director's office. So I think part of the confusion or the difficulty that I've had and that this committee is having is how do we see that our recommendations are being turned into actionable funds out in the community? And really, our job is to give recommendations in a report to the director's office, and from there, our job has been completed. Don, can you help me elaborate on that, or does that sound? Yeah, thank you.
Yes. So I recommend in the recommendations that we go through each one at a time and identify if it's funding or policy. And then from there, we can kind of move forward.
Great. Thank you so much, Don. Karissa, I see your hand up.
Yeah, thank you, Chair. Don, that makes sense. I'm also wondering if we can, as a group, discuss whether something's a prevention strategy or a treatment-based strategy. I think that separation would also be helpful.
Beautiful. Katherine, before I call on you, I just wanted to say that that's exactly why we make up this team, is because, you know, especially, like I said, when it comes to the public comment recommendations, we need people who have that insight to say prevention or treatment, policy or actionable. And we'll be going through that and doing that today. So I hope you guys have some time. We should be here for a little while going through our recommendations and making them concrete. Katherine?
Thank you, and hello, everyone. I'm actually the coordinator of counseling and social work for the Washoe County School District, and I'm honored to be a part of this group. So what I see when I see that first one, and I appreciate Dr. Wagner's comments, but from a school district's lens, what's so difficult for us is how many different NRS mandates and regulations come out without anything specifically identifying the interrelationship and between when we're talking about prevention comprehensively. So it's the same, you know, risk, protective factors, domains, but I have all of these different things. And in the school district, we have to talk about like suicide, substance misuse prevention and intervention, dating violence, eating disorder, bullying. I could go on and on. But what's missing in our schools is a comprehensive, and actually I think in our community, is people understanding prevention to the point that they could identify that the same strategies and a lot of the same tools can be used across risk factors. And I think that's something that's so difficult and missing, that we don't have to have a separate box for everything. And sometimes people are so confused about that. So they think I need a box for fentanyl and opiate use, and a box for methamphetamine, and another box for suicide, and a box for something else. And so I would appreciate a recommendation that helped tie these things together so that people could understand prevention and what is prevention and what works.
That's a really great point, Katherine. Thank you very much for your insight. And I don't know what that looks like, but I just want to, oh, go ahead.
So Chair, can I come in with the assist there?
Yeah, please, Elyse.
Okay, perfect. So again, just to remind everybody, the ACRN is working in coordination kind of alongside a group called the SURGE, the Statewide Substance Use Working Group. They have actually very recently broke into a subcommittee structure, and they have a prevention subcommittee that is meeting next week. And I know there's some crossover with staff. So I think that is excellent feedback, Katherine, that I think probably that committee should hear, because I'm not sure if they will be recommending legislation or policy, but they are working from a policy perspective, whereas we're working from a funding perspective. So I'm not sure, Dawn, if that's a staff question to maybe make sure the SURGE got that note, that comment from Katherine, but I think that would be a really good group to hear that feedback.
Thanks, Elyse. I'll make sure that we send that comment over to them.
Awesome. And we could find, and maybe Chair Sanchez, maybe just something to keep in mind today. Like, I think it's a really great suggestion to split everything out, policy or program. And maybe there's going to be the policy things that we can just couch and say, you know, our recommendation for today is that we've, you know, winnowed out all of the policy and program, and the policy pieces we can pass over to our friends on the SURGE.
Thank you, Elyse. And I think that it's, I mean, my understanding is that, you know, as we go through each page and review our recommendations and we identify policy or prevention or treatment or actionable, these will be included in our report. And then what I'm imagining is that the other reports from like the SURGE group or the other recommendations from local governments that the director's office will be getting will kind of paint a comprehensive picture that gives the director's office some direction, I guess. So Dawn, will you be able to add to, or will we be able to see this on our screens as we work from the top down and denote as a group policy, prevention, treatment, or what is that going to look like?
Yeah, let me see if I can. Do you still see the presentation, but it has the thumbnails? Okay.
Yes.
And
right.
also, Chair, just to kind of piggyback off of Elise's comment, this committee can recommend policy as well. That can be filtered up into the SURGE. So that's great conversation.
Great, thank you. All right, so we'll start working from the top down on the first page. The first one we have is, again, mandatory prevention training in all schools, along with current health training, mental health, suicide, and drug prevention. Is there some type of in parentheses that we want to add to that as far as policy, adding Katherine's comment, thoughts on the first bullet point?
Chair, this is Karissa. Sorry, Dr. Wagner. I want to go back to Dr. Wagner's point, though, that perhaps we could also say from our perspective, we're saying funding needs to be put towards ensuring there can be prevention training and education done in schools around this topic.
Thank you, Karissa. Dr. Wagner.
Thanks, Karla Wagner. Thank you, Karissa. I get that was kind of going to be my question. What is the spirit of this recommendation? As written, it might be a policy recommendation, but is that really what we're saying? Where is the need? Is the concern that there is not training happening because people are not compelled to do it? Or is the concern that there's not money to fund it? And as our colleague has already pointed out, like this is a, you know, this is a massive recommendation. How many school districts are there? How many schools? What kinds of programming are they already doing? Do we have, what level of confidence do we have that this is meeting the need? And what exactly is the need? So like, yes, do I think it's good for schools to have prevention programming? Absolutely. Is that already happening? Is there already funding towards it? Probably.
Right, and how
there are programs that are out there doing that.
Right, and how do we tie our, you know, actionable recommendation towards getting funding towards this issue? What does that look like in the end game?
Yeah.
Dawn?
Where does the funding already come from for the programs that are doing it? I know that there are groups out there that are already funded through other, you know, SAMHSA and HRSA grants to be doing prevention programming. I work with some folks who are doing prevention programming in the schools. So where's the need? And maybe I'll stop talking because maybe Katherine can actually speak to this.
Yeah, thank you, Dr. Wagner. Pauline, I'll call on you and then I'll call on Katherine.
Thank you. I'm just going to piggyback on that because I think that, I mean, for instance, SOS is required in part of the state and not in the rurals. And we all know what happens with unfunded mandates for any agencies, that more and more work is needed to be done, but there's no funding attached to it, which makes it go by the wayside. So I agree. I think this is policy and funding and prevention and all of the above. But I think that if we're doing recommendations of policy change, that funding has to be attached so it doesn't become unfunded.
Thank you, Pauline. Katherine? You're on mute still.
Thank you. To everyone's point, so yes, we do have grant funding. We have the AWARE grant. We have SAMHSA funding. We have worked with SAPTA for years. We're working with our comprehensive community prevention plan with Join Together Northern Nevada. But when you're building everything on grants, it's very difficult to, unless those grants are continued year over year over year, to have things that are sustainable long term. And so what ends up happening is you end up following this grant or this initiative or that initiative, and the availability of the grant funds sometimes dictates the intensity of the programming that you're providing. And that's very, very difficult for us in schools, especially when you're trying to piece everything together. And I would say that it's policy and also funding, because reliability related to that funding is critical, but it's also time. So one of the big reasons that I want to tie all these things together is not because I don't have model exemplary programs that I can use, not because agencies and organizations haven't offered to help and give support through grant funding, not because we don't have that sprinkled throughout our district with 105 different school sites and 64,000 kids and 8,000 employees. It's because when I have mandates to teach so many different things, I don't even have the instructional time left to teach the things, the other things. So if I separated all these things out separately, instead of finding a way to tie them together so that people understood how they were interrelated, and that's what I really spend a lot of time working on doing, then we don't have the classroom instructional time and time in front of the students to do what's necessary. And we know that to do a program to fidelity, we have to have time, we have to have money, we have to have more than 1 year, we have to have reliability. And those are the things that really in schools that we need. We mandate SOS in our middle schools in Washoe County School District, but it's grant funded and we have to find the funding for it every year. And, you know, it's partner dependent too, because of the integrated part of it. So thank you for that.
Thank you, Catherine. And so we have talked about this a little bit before. If we know that there are gaps or we know that there are programs that exist that meet a need or that are serving a community, but they fall short and we find areas that they could use more support in, how can ACRN and the effects of the opioid epidemic be involved in that support? So I have, Pauline, is your hand still up or is that a new one?
Sorry, I just forgot to take it down.
Okay, thank you. So it sounds like for the first bullet point, well, we have two issues, but for the first bullet point, this committee wants it to be identified as policy and funding, but I think we should try to come up with something that maybe changes the verbiage of what the recommendation looks like as we include it. I have two more hands. I think even though Dr. Wagner's on top, I think Dr. Kamyar was first. Dr. Kamyar?
Yeah, sure. It's Farzad here. I mean, along the lines of sort of like the purview or the directive here, are we also determining, because I'm sort of coming from a place where there was these, like, here is the 5 things we're looking at. Maybe it's via the prevention gaps, I think, versus sort of like the John Hopkins policies, you know what I mean? And then do we then bundle all the recommendations under those as a way of organizing? And then additionally, with these recommendations, because a lot of it sounds like it's funding related, are we then going to be saying, so there's this thing called prevention, and maybe there's 5 things under prevention of the total pot, whether that's an annual, budget or whatnot, we think 25% should go towards prevention. There's this thing called treatment, right? Or evidence-based treatment. We think that 75%, like, is this also what we're doing as well?
Thank you, Dr. Kamyar. And great question. The first part, yes, I think that as our recommendations move from this meeting to the next, they will be grouped as prevention, policy, treatment, so on and so forth. But as far as this committee having, I don't believe that we have the ability to say, 75% of whatever the budget is, we would like to go to A and 25% to B. I don't believe so. Dawn, can you clarify on that?
I think this committee can definitely make the recommendation, but ultimately, what ends up going into the state plan is what will be funded based on the priorities.
Thank you, Dawn. And before I call on Dr. Wagner, that's, again, I'd like to touch on that, is that our recommendations, our report is a portion of the reports and recommendations that the director's office will be receiving in order to develop the state plan. So I want this committee to keep in mind that whatever it is that matters to you, that's important to you, that you see as something that you would like this committee to actively denote as an important recommendation as we move forward, that we should be talking about that, discussing that, so that we can have that in our report. And like Dawn said, that's definitely something we can add to our recommendation. We would like to see this highly funded, or a quarter of funding towards something. And then the director's office, as they create their state plan, will take that into consideration. Dr. Wagner?
Hi, thank you, Chair. Karla Wagner here. I'm just looking at the Mercer Needs Assessment and looking for things around school-based prevention. And there is information in here that says in 2019, we did a system-wide assessment 1 in 5 regions was rated to have sufficient capacity in school-based prevention. Most did not. So they're like, do we need to be tying this to the needs assessment? You know, if the needs assessment is saying schools don't have capacity, I don't know what that means, but a lack of capacity was noted for all Nevada's regions in the categories of community-based prevention programming, blah, blah, 1 in 5 was rated to have sufficient capacity in school-based prevention program.
So my understanding is that the needs assessment informs our recommendations. And then, you know, as far as the verbiage of capacity, I think the way that Katherine spoke about it as far as capacity is a time thing, right? And the way that the policy has grouped what she's supposed to be attending to makes it kind of difficult to fill that capacity. So, so I think it's important to keep in mind that we had the needs assessment, we developed some recommendations, and we're going to move them forward, and we're going to do the best we can to fill them or align them with what we believe is important. And I don't know how to say it diplomatically, but we all have, we're experts in our field, you know, we're experts in our experience in that's what got us here. That we're going to do the best we can to group them, like Dr. Kamyar pointed out, prevention, treatment, funding, and then move them to our report, and then that report will be a part of, or hopefully guiding and directing, the state plan to the director's office. I don't know if that made sense at all, if I just looped back around and repeated myself, but that's so far. I believe Karissa was first. Karissa, and then I'll call on Brittney. Brittney, you still have, you're good? Okay. Karissa? Sorry.
No problem, Chair. I was just gonna loop back around to this initial bullet and offer maybe another word is to Katherine's point, what we're recommending is that sustainable funding be developed to ensure mandatory drug prevention, drug use prevention training, because that's what it already says. In this specific bullet, it doesn't even say opioid use prevention training, right? So maybe what we're trying to say in this bullet and other education-based bullets is we think based on the needs assessment, there needs to be better investment and funding put towards sustaining drug prevention, drug use prevention education, and maybe training for professionals, particularly in the geographic areas that were identified by the needs assessment to not have that, the 4 out of 5 that don't have that.
That is it right there. That's it. That's what I'm hoping the rest of the bullet points look like. Dawn, is there a way to, I don't know necessarily that I want you to delete the entire thing that's up there at the top, but basically if we can get the verbiage that we just heard from Karissa added, yeah, that was it right there. In exchange for that bullet point, I think we'll be at a place where we can say, is the committee comfortable with this recommendation, and then move forward. Which is going to be hard, because in the moment as someone speaks so eloquently to reframe that.
Karissa, give me your recommendation. Say it again.
Right. Okay, so better investment that is sustainable to improve drug use prevention education and educator training in the areas identified by the needs assessment that we're not doing that effectively.
Chair, can I dive in on that? So the
Yes.
first thing you said, this is Elyse, the first thing you said, Karissa, was actually geographic areas, which I think is important. But I think if we can expand on that to make it a horrendous sentence, but to say a geographic and like socio-demographic underserved areas would be good, because that covers both areas and communities.
Demographic, socio-demographic, no,
Socioeconomic,
no,
demographic.
demographic, I think. Elyse, one more time.
Yeah,
The geographic
demographic.
and- Yeah.
Yeah, and I think that also will help leave room for assurance of health equity lens if you're thinking about underserved areas and underserved communities as identified by the needs assessment.
Beautiful. Thank you very much, both Karissa and Elyse. And in that, you know, I had a fleeting thought of that as Karissa first reworded the bullet point that we're working on. When she said geographic, in my head it flashed, what about socio-demographic? Of course, I didn't see it as that, but what I said is, you know, through an equity lens. So if anyone on the committee has these thoughts or these ideas as we're going through these bullet points, and you feel that there's something that may be missing or that you'd like to emphasize and include, please feel free to press the button, raise your hand, or just jump into the chat, or not the chat, the you know, unmute yourself and speak so that we can get your point of view and move forward. You know, I don't want to draw this out any more than we need to, but I also thought when you were speaking, Karissa, that the last part of the verbiage in the needs assessment, is that something, Dawn, that the director's office will have available to them as, you know, like if we say in the needs assessment, are they going to be like, what needs assessment? What are you talking about? Or are they going to be, they're going to be well aware of the 80% that it's underserved?
They will, they will be getting a copy of the needs assessment when it's complete as well.
Awesome. Just to confirm, I want to make sure that we're okay with comments and the chat box that we're having by panelists. I just want to make sure that Ms. Rasul and Dawn, we're okay with people saying, you know, adding little bits in the chat. Is that a appropriate form?
I cannot see the chat, so I would prefer if you would be vocal about your recommendations.
Yeah, that's definitely, yeah. Board members, they must, because it must be verbally done. The chat, you know, should be recorded and attached to the minutes.
It will be.
So that, you know, there'll be a point of reference for Dawn, but it's strongly encouraged to have the members speak for the record.
Thank you. So if you do make a comment in the chat box, I'd like you to also raise your hand up and speak on what it is that you're that you have to chat about or that you'd like to say. We'll move forward and we'll stay on this bullet point, but I'd like to call on Brittney.
Good morning, everyone. So I love what you recommended, Karissa. I do have a question. When we're saying better investment that's sustainable to improve the drug use and prevention education and educator training, are we expecting the schools themselves to actually implement it, like with their I think there was a teacher, but I came in late because I had just finished dropping my son. But are we expecting the schools themselves to actually implement the training for the students and the prevention, or are we looking at the schools partnering with community partners to come in and implement some of this training so that they don't have an overload? Or are we looking at the school social workers to implement some of this training? What are we looking at for that?
That's a great point and a great question, Brittney. You know, Katherine spoke earlier on what it looks like in her role and how much these trainings, or sorry, these this work done for prevention within the school districts or the school system is kind of overlapping and boxed into little boxes, rather than as a whole we want you know, and that she's guided by policy that kind of boxes her in. I don't know that this group has the ability to present recommendations and a report to the director's office that would say, free up the school system so that the people that are working on prevention can do their work more effectively. And I don't know that if we should be attempting to do that, but I know that as we group these together, some will be policy and some will be, prevention and policy. And I think that's as far as we can go. I don't know if Dawn or someone else wants to speak on that. And then Dr. Kamyar, does your hand up and comment have anything to do with what Brittney just said and what I just said? If it does, I'd like you to go. If it doesn't, I'd like to have some clarification on what Brittney just brought up. Dr. Kamyar's hand is now down, and I think that we need to acknowledge Brittney's point, and I could use some support on that.
This is Dawn. Can I jump in, Chair?
Please.
I think we also have to be aware of the recommendations that we make, really going back to SB 390 and fitting into any of these categories. And so really tying it all together of where does my recommendation fit with SB 390. So that is also something to take into consideration.
Ooh. Dr. Kamyar? Oh, wait, yeah, go ahead, Dr.
Yeah, this is Farzad. So yeah, that's kind of what I'm struggling with here. This is kind of how I approach things. I was, I looked at that opioids needs assessment that Mercer put together. It was that 68-page document. And it's, there's a lot of stuff in there. I kind of thought that we would be going through each section, because then there's like a section 6, which says best practices, and using this as our guide to be like, okay, they're saying we should optimize the PDMP. What do we think should be done here? What's the priority? What's the recommendation? Versus like, I'm looking at the list of recommendations. That's a recommendation from ACRN 1, from 2. I don't even know what these are. I don't know where they're coming from. There's overlaps. It's not tied to a specific section. I mean, we don't have like a one-to-one to say, has everyone commented on what they think we should do for optimizing the PDMP? And what are our recommendations? Has everyone commented and provided a recommendation for standardizing clinical guidelines? It's right. So there's like, it's almost like there's no guidance for you. We're just sort of randomly going to put together recommendations, and then we're not even making sure that they tie back into 390 or they tie back into the best practices or the needs assessment, the recommendations there. So that's what I'm really struggling with.
Thank you, Dr. Kamyar.
So this is Dawn. Chair, may I?
Please.
So Dr. Kamyar, these recommendations are from every member of the committee through the survey that you guys did. So going back up here, you guys at the beginning of the survey, we did the gaps that were in the needs assessment. You prioritized the gaps based on what you felt was the highest priority need. And then you guys made recommendations based on the way you scored your gaps. And these are the recommendations. And so they're not in any particular order. They're actually just in order of the way the survey was filled out. So whoever filled out the survey first, that is the recommendation. And some people put many recommendations. And so that's why there's more recommendations than people on the committee. And then down at the end of this presentation, this is how you guys tied in all of these recommendations to SB 390. So 8 of the recommendations said it ties into SB 390 because it's expanding access to evidence-based care. So that's how it all kind of fits together, if that helps.
Thank you, Dawn. Dr. Kamyar, is your hand still up or is that a new one?
Yeah, no, sorry. It was just,
Thank you. I just didn't want to skip you if your hand was up. Pauline?
Thank you. So out of all the recommendations listed are already tied to our legislation.
Correct. You guys tied them to your legislation already.
So nothing that's listed on the recommendations doesn't fit our category or requirements.
Well, at least the intent doesn't, right? So we can change verbiage and we can change, we can direct or, adjust the recommendation to go towards policy or towards treatment, prevention, whatever it may be. But again, these recommendations were written in by each member as their recommendation. And then there was a connection to where it fits into SB 320. Sorry. And so yes, in a way they all are, but in a way we need to go through them, clean them up, and then move them forward. Does that make sense? And am I making sense also?
Yes, thank you, Chair. I just was wondering if there were some that didn't fit our requirements that we could, since that's not on our purview, that we could just take out. But thank you.
Don, that's correct, right? What Pauline just pointed out. Like there should be none that are not connected to.
There should be none that are not connected to SB 390. That being said, if this committee feels like any of these recommendations are too broad, or you want to wordsmith them or change any verbiage in them, or you think that it's just not an appropriate recommendation and it doesn't fit, that's why we're having all the discussions today.
Beautiful. I think I have Dr. Kamyar's hand up again.
Yes, Farzad here again. Okay, so this is Farzad, yeah. All right, so some clarification. In the needs assessments, there are a bunch of headings like identified gaps. There's like this methodology, priorities, structure, and then identified gaps. And then there's a section at the very end and then there's risk factors, which look like there's more sort of identified gaps maybe. And there's a section at the end that says best practices. So does SB 390, and those are different, right? The headings are somewhat similar, but they're different. So are these needs via SB 390, are they from the needs assessment? Or is it from the best practices of the needs assessment? I'm trying to figure out where and to categorize. I'm not seeing where that is. Because like I see identified gaps, lack of unified statewide prevention programming, harm reduction, access to treatment, crisis, pilot services, workforce shortages. And then I see best practices, and it's like, here are the 10 key recommendations. One is optimize the PDMP, 2 is standardized clinical guidelines, 7 is treating OUDs, 9 is expanding harm reduction. So are those the headings that we're using? Like, where's this list of headings that we're trying to lump all the recommendations to coming from? And which one are we going to actually be using? I'm seeing different ones.
Don, can I get help with that one?
Yeah, I'm sorry. I'm trying to wrap my head around the comment. Is Dr. Cantrell still on?
I believe so.
Is Dr. Woodard on?
We have Dr. Cantrell, but it sounded like a little feedback, so we'll see if we can get her available. Let's give her a moment to work. We had you for a second, Dr. Cantrell, but we don't have you now.
There we are. Can you hear me now?
Yeah, there we are.
I'm sorry, I wasn't expecting to talk, so it just took a second. So what was the question again?
I'll let Dr. Kamyar repeat, but in overall, it's confusion or we need direction on the Mercer report and the overall headings of what it is that we're seeing where it is we're seeing gaps and how we're tying our recommendations to them. Dr. Kamyar, can you
Yeah, sure, Farzad here.
elaborate?
Dr. Kentrell. So basically, here's the question that I have is like, I feel like there's a bunch of different headings and I'm not sure what ties everything together. In the recommendation, the needs assessment documentation, there's a whole lot of stuff, right? There's a whole lot of headings. There's, you know, section 3 is opioid impact. And there's a bunch of stuff there. There's risk factors. There's like gaps that have been identified. And then the document ends on a best practices and like, here's the 10 principles. And it feels like our SB 390 possible actionable items are sprinkled here and there. So I'm just not sure what we should be tying these recommendations to and where did that list come from? I was sort of operating under not here are the identified gaps, but hey, here are the 10 things that we're saying are the best practices. Start to put your recommendations under each of those, given here are the gaps and here's what's going on and here's some recommendations. But then I'm not seeing that list matches. There's just so many different documents I've opened up right now. that matches what Dawn was referencing, which is like, here are the SB 390 categories. So it's different.
Right.
Dr. Woodard, oh, sorry, I'm sorry.
Sorry, go ahead.
I was gonna say, Dr. Woodard, do you want me to talk about the reorganization of the report and the gaps, or do you want to answer his question?
I'm happy to answer the question. I think reorganization would also be helpful. I defer to Chair how you'd like to approach this.
I'm sorry, Dr. Woodard, I missed the end of that. I was reading a chat and I totally spaced it.
So thank you, Chair. Stephanie Woodard for the record. I am happy to address Dr. Kamyar's question, and then Dr. Cantrell can also provide a little bit of information as it relates to the restructuring of the needs assessment. Does that work for you?
Yes.
Okay. All right, great. I don't know if everybody has access to previous presentations to this committee. Sorry, Stephanie Woodard for the record. But Dr. Kamyar, I would point you back to the actual legislation. If I could share my screen, I can pull up a copy of that presentation. And this may actually refresh memories. I know you guys have had a lot of presentations over the last couple of months. So can everybody see my screen?
Right now it's, oh, there we go. Yep, we're in.
Okay, all right. So earlier in this meeting, Dawn anchored everyone to SB 390 and what the actual requirements are or obligations of the committee as it relates to the legislation. So just very briefly, I think this may also help to reorient and anchor everyone to how SB 390 was even developed. Briefly, the role of the advisory committee and how all of this kind of fits together. So just to be clear, we have used the Johns Hopkins principles for use of funds for opioid litigation in the structure of SB 390. And this really is sort of a guiding document for everything that the state is doing as it relates to opioid funds from the litigation. So principle number 1 is to use the funding to save lives. And this, I think, is also very clearly called out in the legislation as a known priority, right? We would not do well by anyone in the state if we allowed the funds as it related to opioid litigation go out into the community and we did not prioritize funding specifically to save lives. The second is to use evidence to guide spending. And so in the legislation, and Dr. Kamyar, this addresses directly what your question was. In the legislation, it was identified because remember, the needs assessment is not the first time that we have done this work. People have been doing this work for many years. Many of the subject matter experts that are on this call have been in this work for a long time. Many of them have actually contributed to the body of knowledge that went into the needs assessment. The needs assessment is comprehensive in that it takes into consideration all of the work that has been done to date, but it's a concise synopsis of many, and Dr. Cantrell can speak to this, many documents that have been shared to help to author the needs assessment. So I think we all need to recognize the enormous amount of work and energy that has already gone into addressing the opioid crisis in the state. From that work, we know that we have significant gaps, right? The needs assessment wasn't needed in order to tell us the gaps, but we did need to put as much information in one location as possible to help clearly articulate what the needs are. So we know, and we knew going into writing SB 390, some of the critical gaps that exist within our state, and those are here under Principle 2. So when we're talking about where do the recommendations for the committee, what are the core topics or issues, it would, I think, be helpful to this committee to use this list to then identify, is this recommendation related to reducing the incidence and severity of neonatal abstinence syndrome? Or is it evidence-based prevention of substance use disorders? I think that may help the committee organize the recommendations and recognize that these are already identified known needs, right? And so the recommendations are the how do we actually address the need? What is the action? What is the strategy? Is it a funding strategy or is it a policy strategy? Or sometimes it may actually be both. So as the committee works through this work, potentially using this as a guide to identify the recommendation fits under any of these headings. And then of course, in the legislation, there is the ubiquitous kind of catch-all. This is not a self-limiting list. This is just a list. So if there are other strategies or actions that this committee recommends that don't fit neatly into any of these categories, that's okay. We can have an other area as well. So don't feel limited or boxed in by this, but this may actually help the committee structure some of the work as it relates to the needs assessment. So I'll pause there and just see if that helps answer Dr. Kamyar's question.
Yeah, Farzad here. Right. Okay. So in seeing this, it's almost like I've forgotten all about this because I don't know that when we're reviewing like surveys or inputting it tied to these specific principles, it tied to these specific like collection analysis of data, you know what I mean? So I guess it would be really helpful if we had one document that's put everything together and said, hey, here's our 5 principles under principle number 2, here's 5 bullets, under those bullets, here's the gaps, here's this, here's recommendations, versus trying to like pull all this stuff together just because I feel like I haven't seen this list in a long time or been up to date or was tying it right. I was trying to tie everything to the most recent needs assessment document that I got, section 6, best practices, and looking at each of those 10 recommendations and going from there.
Thank you, Dr. Kamyar. Dr. Woodard, do you still have your hand up or can I? Okay.
No, I'll put it down. Thank you.
So yes, Dr. Kamyar, I totally see what you're saying, and I am with you on the feeling distant from the information that has been provided to us over the months. At the same time, it is the goal of this group in the next 3 meetings is to have recommendations available that we can put into a report that Dawn and her team will put together that then we can review and approve and move forward to the director's office. Again, we're a portion of the recommendations that the director's office will be receiving. But if we took the time today to reset and create one document with all the information that we've been presented, and then met again, the likelihood that we are meeting the timeline that this group is being held to would be unlikely. So at this point, I think the way that we have these pages of recommendations, from ACR1, ACRN2, and so forth, is because we have been presented with this information, and I was totally on page with what you were saying as far as we're not, or I'm not seeing how the initial needs assessment and their outlined 7 sections, how we're connecting these recommendations to them. So basically the way that I understand it is that information was presented to us. With that information, we were confused and we had questions. Information was presented to us again. And then we were provided a survey, and in the survey, we were able to tie what we felt strongly about to our recommendations and get those to where we are today. So I see what you're saying, that Section 6 best practices optimizing the PDMP. We don't have a recommendation that ties into that specifically, but we were informed and we did consider what it would look like to optimize the PDMP. But what we actually came up with is this list here. So I guess we're in a bit of a challenging spot. Is this committee comfortable working through the recommendations that we have? And again, that's with this group being filled with subject matter experts, and then get that into a report? Or do we need to do something like what Dr. Kamyar is suggesting and reorganize the information into one document so we can better see it and break it down? Dr. Kamyar, I see your hand up.
Yeah, Farzad here. So yeah, along those lines, it would be great to see the document that Dr. Woodard just presented. And it would be great to see the survey questions again, to see if, like, for example, on the survey, were we even asked about the PDMP, right? Maybe I don't remember. I'm not 100% sure that the survey questions that we were asked that we were able to put in, again, tied back.
So I know
I'm just using PDMP as one example, right?
Yeah, perfect.
Because if there's a mismatch between what appeared on the survey and what we need to tie everything back to, then we can't. I would say we wouldn't be confident that the recommendations we're saying are the sum total, are all encompassing. They address every single topic, which I think is very important, right? I mean, what I envisioned was, hey, here's a whole bunch of recommendations. Here's the guiding principles. Like, here's the stuff that Dr. Woodard just presented. Here's gaps. What are your recommendations? Let's make sure we're providing recommendations for each thing, right? And then we can prioritize amongst those recommendations as well. But if it's not a complete list and it's not tied one-to-one-ish, then we might put together fantastic recommendations, of course, but then we've missed certain things, right? Or we've overburdened other things.
Yes, I hear you, Dr. Kamyar. And, so I specifically remember that there on the survey that we all got a chance to fill out, there was not one that said specifically, or that touched on specifically to optimizing the PDMP, but the options that we had were all related to the points that we had to hit through SB 90, and there was an extra section for other. If there's another area that was identified through the needs assessment that you're concerned with, please mention it here so we can add it to our recommendations. So, using optimizing the PDMP as an example only, if that was something that this committee wanted to be sure that was included in the recommendations, then somebody could have or ought to have written it there. But here's a question for Dawn. We have these recommendations right here, but does that mean we are limited to what we have here as far as approving, editing, or removing? Or to meet the concern of the committee, can we add in the moment recommendations?
No, you're not limited to this list, but just kind of going back, let me share my screen again. So the survey, I'll do a couple of things. So I'm going to share the presentation again. The survey it connected all of these gaps. And so it said data. And then when we had sent out the email to everybody, it listed all of these, including the PDMP enhancement. But, we didn't necessarily point that out in the survey because we had already written it all out in a document for you. So all of these gaps are what you guys ranked in order to develop the recommendation. So I can try to share the survey if you want me to do that. Chair.
I don't know how, I guess if you were going to share the survey and those that were concerned opened it up and went through it, and we found that, I think the only thing we're going to find is recommendations that we don't have included already.
Right.
So and at the same time, while we're working through the recommendations that we do have right now, we would be taking attention away from that because we'd be concerned with what isn't in there, which is, I'm not opposed to one or the other, but I think as far as making progress, I think that we can maybe table that idea, and you can email everyone the survey again right now, so that while we're talking, they can have it open or something. But I think what I'm seeing as the concern is difficulty or challenges with what we currently have as a disorganized grouping of recommendations, and the opportunity to miss some target areas that this group is concerned with. If that is the case, then I would ask that this group come together and make some additional recommendations.
Chair, may I? Can we recommend that we go through the rest of the recommendations and not necessarily have discussion on every single one at this point, and circle back to the ones that we feel we need to talk about? Is that a possibility for this group? Because maybe in some of the recommendations on the different pages, maybe somebody has made a recommendation that you're like, oh yeah, there it is, but we're still stuck on page 1.
Yeah, I like that.
Okay. Chair, should I hand it off to you? You can read through the recommendations.
Yeah, that'd be great. Thank you. Dr. Kamyar, I just want to make sure that your hand isn't up as a new one, and if it is, please go ahead. Okay, thank you. So if I don't know how you would do it, Dawn, but basically I just want to confirm that the group is okay with the editing of the first bullet point on recommendations from ACRN page 1. So if I could see that up somewhere as you share your screen, that would be great. Whew. Bullet point number 1, we have changed it from mandatory prevention training in all schools, along with the current health training, mental health, suicide and drug prevention, to better investment that is sustainable to improve drug use prevention education and educator training in the geographic and socio-demographic areas identified in the needs assessment. This is looking to be one of the recommendations that this committee feels comfortable with, and at the same time, I'd just like to acknowledge that it does not meet all the need that has been brought up as far as Katherine's concerned with the challenges of negotiating, time and different trainings boxed in by policy. So we have something, and I don't know that we can have the full effect that would support Katherine's concerns. There we go. But it does seem to align with both SB 390 and this committee's. It aligns with what we would like to recommend. Dr. Wagner?
Thank you, Chair. Karla Wagner. Can I just wordsmith a little bit? Dawn, could it just say sustainable investment in substance use prevention education? Like not better investment that is sustainable in, just sustainable investment in substance use prevention education. Investment in sustainable investment in substance use prevention education. Yeah. Delete improve drug use prevention education. Yeah. Is that okay?
Yeah, I like that. So this is a little bit a part of what I'm confused on. At this point, we have wordsmith, we have changed bullet point number 1. We, I think, feel good about the changes to bullet point number 1. Now, do we need to vote on this individual recommendation to be included in our report? Or
Chair, if you would like to take a motion to move this forward for prioritization.
thank you. I was super confused. Okay, so I don't make the motion though. So can I get a motion to move this recommendation forward into our prioritized recommendations that will go into our report?
So this is Pauline. I'll move what's written right in front of us forward to a priority.
Thank you, Pauline. Do I have a second?
I'll second.
This is Cornelius Sheehan, Mr. Chair.
Hey, Cornelius. Please.
Hi, good to see everybody today. I'm thinking that we ought to look at everything and then go back through and talk about what gets included and not included versus item by item. So if we haven't seen item 10, what's the importance of item 1 relative to item 10? Is that making sense to folks the way I'm posing that?
Jessica here. I agree with that as well. I think we should go through everything and then we can go back through and say we approve.
So this is Pauline again. I'll remove my motion.
I also wanted to comment, Cornelius, again, I really like the change in languaging. Things like better and improved, they're not only ambiguous, but they imply a baseline that's established and known. And I think we need to be more precise, per Dr. Wagner's recommendation. So I'm in agreement with that approach in general.
Okay, so I'm a little bit confused, or I just need a little bit of clarity and direction. The suggestion was that we read them all or go through them all, but my confusion is like I'm going to read the next one, right? Like you're good with that? Like we're going to read them all instead of doing it page by page. We're not going to just vote on the whole page. We're going to go through each bullet point. That's all you're mentioning, right?
That's what Cornelius, again, that's what I was thinking, Mr. Chair, is looking through and then just perhaps, noting that one is in the realm of acceptable and others may not be in the realm of acceptable as recommendations. We might just exclude those as we go, then work with the catch of acceptable recommendations and then start to prioritize them that way. I also think categorizing them, like Dr. Kamyar had suggested, so there's a little taxonomy in where they fit. It'll give us an opportunity to do that too once we've kind of winnowed them down. Does that make sense, Mr. Chair?
Yes, absolutely. I was totally thrown off when you first said it. I was like, I was totally on a different line and I was very, very confused. But then it was the first thing that I thought, which totally makes sense. I don't know why I went that way at all.
I have that effect.
Okay, so let's move to bullet point number 2. And yes, I would like to, like you suggested, and like it has been suggested, sort the bullet points as we finish them with a little type of notation that says where it falls into the recommendations, whether it be prevention or whatever it may be. So for the last one, I guess we have agreed that that one is both prevention and policy. Does that sound right? Do we need to add that at the end of the edited bullet point 1? Or is that the type of categorization that we're looking at?
Chair, this is Karissa, if I may. I believe
Karissa.
we acknowledged it as prevention and both policy and funding.
Let's do it. Beautiful. All right, moving on to bullet point number 2, intense media coverage regarding prevention, how to recognize an addict within your circle of influence, and effective steps one can take to help the person. Ads should be running across social media, TV, radio, and print, specifically billboards and flyers. I'll just start with, yes, I really like this one. And I think the committee being subject matter experts also is in alignment with that. I think all we need from this point is a revision of verbiage and some wordsmithing, and we can move forward. I have Pauline, and then I have Elyse. Please, Pauline.
Thank you. So when I saw this one, I'm not sure how it works across the rest of the state, but I know that we all have our community coalitions, and like our community coalitions do a great job with the funding that they have. So, I mean, additional funding, of course, would increase that. This is one of those areas that I feel like may already be funded and we don't know about it. And if it's already funded, then to me, it's not going to make it to the top of the list. So that's where I get a little crazy with all of this, because I just think that yes, media coverage is absolutely critical, and I think there's some places that are already doing that. So I just want to put that out there that I like it, but the way I look at it, that might not be a priority for me, at least, if it's already being funded.
Perfect. Thank you so much, Pauline. I'm gonna call on Dr. Woodard next, and then I'll call on Elyse and Karissa. But before I do, I want to reiterate that, Pauline, that's a great point. I don't think that this committee needs to focus so much on what is it going to come out in the end as a priority. But just like the first one, which was, always going to be the hardest, going to be difficult to work out and navigate through, but we did it. I think that the director's office is going to get a ton of recommendations, and they are going to be overlapping, and we are going to see, we're not trying to supplant anything, we're trying to supplement something. So in my experience, I don't think there can be enough media coverage regarding prevention and basically this bullet point. I don't think there can be enough funding going towards that. So if we prioritize this as a recommendation and it goes forward and goes through the objective tool and comes out the other end and it's number 26, and it's important to us, we can make a note and move it forward. And if it comes out number 26, maybe that's because there already is a ton of funding, and that's where we stand. Dr. Woodard, did you still want to speak?
Stephanie Woodard, for the record. Chair, you actually just spoke exactly to the point that I was going to make, that at this point, the committee is really just tasked with identifying recommendations. Recommendations will then be applied to that objective tool. That objective tool will help to identify the impact, feasibility, and urgency of each of the recommendations, at which point then they will come back to this committee, and this committee can then review and look and see where it fits within the prioritization, and then determine if they want to move forward with the way that those recommendations have been ranked by priority or not, to then be included in the final report to the director's office.
Thank you, Dr. Woodard. I'll call on Elyse, but before I do, I'd like to say that we are subject matter experts. And if it is important to you and it ties to SB 390 and we don't have it up here, we'd like to hear it at the end. If it is up here, we'd like to adjust and correct the verbiage so we can get it moved forward as one of our recommendations. Elyse?
Thank you, Chair. Elyse Monroy for the record. So actually kind of in alignment with that, Chair, I have a verbiage recommendation and a quick anecdote to share why this is so important. I appreciate and agree, Chair Sanchez, that definitely there's like no amount of money that would be too much to put towards messaging. But if that messaging is not appropriate, culturally competent, in a language that people can understand, or a message that is meaningful, then we're wasting money. So, you know, in Nevada, we've seen a complete surge of Hispanic males overdosing, dying by fatal overdose. And in 2020, when my program started to reach out to the community to talk about this increase, I thought we were going to say, how can we get you naloxone? What do you need? And the question I was met with is, what's an opioid? What's fentanyl? So, like, there definitely is an amount of money that is too much if we're just putting it on billboards and flyers and not testing the message and not making sure the message is meaningful. So I think how I would propose to wordsmith this would be to add language related to messaging that is culturally competent, messaging that is not just in English, and also not just in Spanish, but in other languages that people that are using drugs use. You know, I do know currently there is a lot of money already spent on messaging. There's already stuff put on TV. There's already stuff on billboards. And I don't know what or how that messaging has been impactful if we have communities that are literally suffering from overdose that don't know what opioids are or don't know what fentanyl are. So yeah, just something to think about. But whatever messaging is created needs to be evidence-based messaging for prevention of substance use, and it needs to be culturally competent, culturally informed, and in languages that people can understand. Thank you.
It's Karissa Loper. I just want to piggyback on Elyse and add that I think it needs in some way to be tested. And maybe what we're saying when we're saying intensive media coverage, we're really saying we need tested, evidence-based, culturally competent messaging media campaigns across the mediums used by the people that are using substances. So is that TikTok at this point? Like, I am not a media expert. So because we have dealt with this in public health and vaccines, right? Like, how do we really actually reach some people who are not looking at, I had, you know, people at my socioeconomic level be like, oh, I don't look at billboards. I was like, but all our signs are on billboards. And you're telling me you don't even look at them. So I think we need to also know the mediums, like the original bullet said, that people use, and we need to make sure those messages, those tested messages, are on those mediums.
So here is what comes to mind when I thank you both for sharing also, and thank you. It's really great points. But here's what I come across when I think about what was said is that we make a recommendation, we wordsmith it up, and it looks good. It fits to what we want it to be. But how much can we guide what happens and how? Elyse made a great point that you can throw $1 billion at it, but if it's done inappropriately or inaccurately, or not in a way that yields the results that it was meant to, what does it matter? I don't know that we can affect that back end, can we? I mean, we can wordsmith it as best we can, which we have some pretty good suggestions on what that would look like at this point. But what can we do moving it towards that back end?
So this is Elyse, Chair. I think, and maybe staff can verify, but I think if we create recommendations that are thoughtful enough in that we're saying we want messages that are evidence-based and mediums that are evidence-based. As the state is developing their funding requests, that's language that can be put into an RFP. So as an example for folks that might not know the process, what maybe could happen, and state, correct me if I'm wrong, you know, as opposed to saying this notice of funding is going out to promote evidence-based or to promote messaging about drug use awareness, it can instead say this funding is going out to promote messaging, evidence-based message development in tested mediums to promote awareness about drugs or something like that. So then it allows like more specific activities to be funded, if that makes sense.
Yes, it absolutely does. Let's, you know, I was thinking of how do we help Dawn get the changes to the bullet points as we go through. And Ms. Rasul pointed out that if there's a message in the chat, it will be included in the minutes. But maybe in order to expedite what the verbiage will look like, we can have, at least right now as a baseline, Karissa and Elyse write something in the chat, and as you write it, you'll be comfortable with it, share it with us, not necessarily through the chat, but you can speak it to us and have Dawn write it once we have it penned out.
Chair Sanchez, it's not really appropriate to utilize the chat for discussions on agenda items for the board members, so everything should be vocal.
Okay. Thank you, Ms. Rasul. Okay. So let's go. Okay, I'm still on it. I have it on my screen and I have it on Dawn's shared screen. I think the only issue that we're seeing with number bullet point 2 is that we would like to wordsmith it up, and that we have concerns about what it looks like in as it's actionable, but we want to ensure that it's culturally competent and evidence-based. But again, I think that the evidence-based is kind of like a foundation of what is being considered and what will be passed up as recommendations as the director's office receives it. So I don't think that every one of I get what you're saying about we need to be specific in the language so that it actually means something and does what we want it. We hope it does. But I think that the evidence-based part at least is like a must, because it's already written into SB 390 language. So how can we adjust the language on bullet point number 2 so that we can vote or get a motion to approve it as a recommendation from this committee? And I guess
Chair,
I'm
yes. Sorry.
Please, no, you could.
This is Cornelius. And Dr. Woodard, you may be able to help me out a little bit here. Am I correct in the idea that the state already has some production underway around this, or actually even being broadcast? And if so, then to measure, to take a look at what's out there and the effect that that's had so far would also be part of this recommendation? I'm almost certain there is, right, Dr. Woodard?
Stephanie Woodard for the record. Yes, you're correct. So there's absolutely latitude to include some language like that in this recommendation.
Okay. So something about the assessment of current, media, current things that tie into this, and then an expansion of, so maybe instead of the word intensive, just expand based on assessment of current. That may not be the actual languaging, but that's just conceptually.
Yes, and so can I get the changes page back, Dawn? And I'm not the strongest at this, so I could use some support. But basically, if we're looking to change and complete this bullet point, assessment of current campaigns that are currently being implemented, and I don't know.
So maybe Mr. Chair, Cornelius again, assess efficacy of current campaigns, current relative campaigns. Is that okay with folks? Assess the efficacy of current related campaigns.
And then maybe to ensure that they are evidence-based and culturally competent.
So I was thinking of those as two separate ideas. So one is look at what we already have, what's working, and then the second, ensure that any campaign, any and all, are evidence-based and culturally competent, multilingual. And presented on, as someone said, I think Elyse said earlier, or somebody did, sorry, you know, TikTok, etc. So I'm not sure how we would word the you know, breadth or reach of these things. Platforms, I suppose, is that the term for that?
Yeah, but I think on the first section, it would be assessment of efficacy of current related campaigns, and or yeah, I guess you can put it there too, and use on current or modern platforms or something. But yeah, that works to ensure any and all campaigns are evidence-based. I mean, any and all.
I would just say, like, ensure all media campaigns. We may need to put media in there.
This one
there are lots of
specifically relates to
campaigns.
media. Yeah.
Yeah,
that's a good point.
On all, we could say on all platforms, but I would say on a diverse set of media platforms.
Yeah.
Nice.
I've done a lot of this with vaccines before, and they're like, oh, you gotta use all these kind of words.
Now the first change, assessment of efficacy. Elyse, is there something that we could add to that to include that giant gap that you have come across of people not even being aware, or being aware of so little when it comes to opioids?
No, Elyse Monroy for the record. No, I think that how it's captured here is good. Yeah, with culturally competent and multilingual. I'll just say, like, for the record, I think that the baseline of where this messaging should be is like in a language that people can understand, but like what we have to reach for is like messages that are actually impactful to the people that are hearing them and culturally aware and competent. So, but that's just my little soapbox. But I think this is a really good kind of workshop of the language. So thank you, Dr. Sheehan and Karissa.
My pleasure. It's Mr. Thank you, Elyse. Mr. Thank you.
Okay, but I think that we need to add, as it relates to opioid use, use disorder. Is this one meant to target intense media coverage regarding prevention? And then it says to recognize an addict.
Mr. Chair, Cornelius Sheehan, for the record, is that implied in everything we're doing? Do we need to, wouldn't that language be redundant, maybe?
Good call, thank you. Yeah, that's.
Oh, you're welcome. It's sorry for the challenge. I just hoping to.
No. Well, when I say it, I don't hear it, but when I hear somebody else say it, I can hear it. So that's great. We're gonna need each other.
Interesting phenomenon.
Okay, how do we feel with number 2? Are we comfortable with it? Would we like to make a motion to move that as our second bullet point recommendation? Can we get?
Chair, this is Karissa. Did we decide we were gonna write all the changes and approve them all at once?
Oh yeah, my bad. My
problem,
mistake. Sorry about that.
Did we also want to just quickly, I was just thinking about the categorization. So I believe those are both, they're all prevention. They're both prevention. I'd say they're funding.
Supplement. Sure.
Because what we're trying to say is invest in an assessment of, I think, invest in an assessment of efficacy of the current related media structure, and then
supplement the changes that need to happen, right?
Yeah. Is the third bullet maybe policy too, Elyse, or anybody else? Any thoughts on that? Are we trying to tell all the counties and everyone that would be implementing this kind of funding, they need to use their funding to ensure the media campaigns are evidence-based?
And culturally competent?
That's a really good question. I'm not sure if it's policy or not, because I guess when I'm thinking about policy, I'm thinking of like what the legislature would do. But I also think that, you know, as important it is that things are evidence-based, I think it's also important to just remember like how fluid this issue is. So 5 years ago, like we were not talking about fentanyl, but now fentanyl is what's killing us. And in 5 more years, we're going to be talking about something else that none of us have ever thought about. So while it's important to use evidence-based strategies, if we want this work to be sustainable, we probably don't want to put ourselves in like a fentanyl / opioid / meth box, even when it comes to strategies. So I think this is a funding one.
And Don, can I see that changes page one more time? Do we want to add invest to the assessment of efficacy? Or is that just the recommendation? Assessment needs to be done. Sure, or I guess it's funding, so it comes with this invest. Sorry about that. Ensure all media campaigns are evidence-based.
And Mr. Chair, just really quickly, if it's helpful, this is Cornelius Sheehan. Part of why I was thinking that as far as the assessment of efficacy is if we have current campaigns running that the state's invested in, and as someone else commented, fentanyl and overdose deaths are on the rise, there's a disconnect there, right? People are dying and there are campaigns advising them about the dangers of drugs. I haven't seen the campaign, so I'm uncertain, but I know there's product out there. So what's the effect? What's being missed? What needs to be changed? I just wanted the committee to understand my recommendation that we include assessment of efficacy of current campaigns.
Yes, thank you for the clarification, Cornelius. It makes a lot of sense, and I appreciate your comment.
Thank you.
I think we're good on this. Can we move to bullet point number 3? Is everyone okay with that?
Yes.
All right. Bullet point number 3 is interesting. All of the above implemented for all groups affected by the crisis. So it may have been, like Dawn said, that this came in the order that it was received, as far as people going through the survey and then making their other comments, or just in the comment section adding a comment. So one of the committee members felt very strongly about all of the targeted options for recommendations be included. So as far as bullet number 3, I don't think that there's a way to reorganize that or readdress and wordsmith this one up. So I think we can acknowledge that we are doing our best to touch on all of the implementations for recommendations and how they affect the groups or the people affected by the crisis. And we can move on to bullet point number 4. Does that sound good?
Yes.
Okay. Bullet point number 4, opening more beds for crisis and withdrawal management that should be readily available despite an individual's insurance status. I love this one. I don't know how to reword it or wordsmith it up, but my experience has been that withdrawal and specifically detox centers are a giant challenge, and not just in Nevada, in the country. So if we were able to help this in some way, what would our recommendation wording look like? Pauline?
Thank you. Can we include in there just creating the infrastructure, like effective infrastructure to open more beds? Because I agree with it, like we need it. But I think we all know that the workforce, even if we had beds to open, we need the workforce development to do it. So maybe creating infrastructure.
Yes, and Elyse, I saw your hand up, but then I saw it down. I'm going to comment on this one. I think that this one goes deep. Like you said, it's not only infrastructure, workforce, the actual physical facilities that we would like to see opened and available, but also this one ties into the structure of the service, as far as it missing, it not really fulfilling its purpose. Again, in my experience, you attempt to go to a detox, but if you don't meet the criteria, which seem to be pretty rigid across the country, you very likely will be turned away and not have an opportunity to detox and be involved in recovery services as a whole. So being that it's a very broad bullet point, I'd like to hear from Dr. Wagner, and then I'd like to also start adjusting and addressing the language. And if we need to split it up, we can do that as well.
Hi, thank you, Chair. Karla Wagner. I just to kind of riff a little bit off of what Pauline just said, and I think this is a separate bullet point, but one that I would like to kind of propose underneath here in the realm of workforce development. I wonder if we could make a recommendation for something like creating a scholarship fund to support workforce development and training to assist people affected by the opioid epidemic in building the workforce that is needed to address concerns. So I think that, so specifically the recommendation would be something like building a scholarship fund dedicated to workforce development that would assist people to move into this workforce and build that infrastructure that Pauline is suggesting. We have models for that with things like the Millennium Scholarship that came from the tobacco settlement dollars. This isn't my idea, my colleague suggested it, but I think it's something that I would like to put on the table.
Yes, that is absolutely dead on what we're looking for. And so we may see repeats as we go through this, but that's going to be okay. We may see things that touch what we've gone over, and that is a great idea on how to supplement or sustain a workforce that can come in and help with this. And it may be something that the director's office looks towards as we recommended. But I wanted to, I'm just reading as she's writing. I wanted to say that, oh yes, and it ties into SB 390. So we can attach this easily. And that's what I'm looking for from anyone else that isn't, that we haven't heard from yet. If you have something along these lines, we can tie our recommendations to SB 390 through verbiage and also the intent. Again, I know I've said it before, we are the subject matter experts and we're trying to help our community. So what you have is important. I'm not sure, Pauline, if you still have your hand up, but I have a list going from the top. Elyse is next. Elyse.
Thank you, Chair. I'd actually just like to request if we could actually separate out creating the infrastructure and funding the beds, because I think those are two very, so creating the infrastructure is something that's so needed, but that's like something that's probably going to take years and years to invest in. And we may and probably do have beds in the system that can be used now. I know that getting access to treatment is complicated. We need more beds, but we should be able, if we can use funding to fund beds now, we should do that. So I just wanted to see if we can separate those out. I love the idea, Dr. Wagner, of a scholarship fund. Also beyond the Millennium Scholarship, I think under the Sandoval administration, but it could have been Sisolak, there was a scholarship fund, I believe, created for teachers that teach 1 year after school. So there's definitely a lot of precedent for that kind of investment in the workforce. I think that's all I have to say now, but if anyone has any other thoughts on what treatment infrastructure looks like, I think it would be helpful. In my mind, it's probably facilities, beds, but it's also like linkage to care systems, community-wide case management, the HIE, it's probably reimbursement models. So it's really big, but if anyone has any other thoughts on what specifically infrastructure investment would be, I think that would be helpful.
Yes, thank you very much, Elyse. I'll call on Katherine next. It looks like Dawn was able to type in and catch a little bit of what you had mentioned, Elyse, and that's what I would add as well. Is when I think of infrastructure, I think of facilities specifically, there being a shortage, and then of course with consideration to the rural areas specifically. And yes, as we are getting the last of the verbiage into the split. It looks really good. Katherine, can you share with us, please?
Yes, thank you for calling on me. I appreciate what Dr. Wagner said about the scholarship fund dedicated to the infrastructure work funding. I think that's really, really needed. One thing I wanted to mention, because I think the point here is that sometimes we have beds available, but they're not for individuals that have certain kinds of insurance. And those beds need to be available and opened up. But in addition to that, I would like to see something not targeting an individual's age, sex, a lot of times, or other thing that limits their availability to receive or access the care. So for example, well, we're not going to see adolescent boys, or we're not going to see adolescent girls, or we won't see people, we don't have a place in our community for someone who's under 12, or, something like that. I would like to see some comprehensive language that encourages making sure that along the continuum of individuals that are comprised in a community, we have all of the individuals covered in this care.
That's perfect. Thank you, Katherine. And that's exactly my experience. And what I'm seeing as well is that we may have a limited opportunity for detox or inpatient facilities, but it's even more limited, like exponentially, based on youth. That's it right there, is how and it's both mental health and substance use, how the shortage and the amount of support that is needed for that community is, we're lacking huge. We need to do something. And I don't know what that would look like in verbiage, or if they would be two separate things. I see that it's being typed together right now, which I appreciate. But thank you for bringing that up, Katherine. That's going to be, if we limit it to not include youth, then I think we're missing something drastically. And again, we have the premise behind the whole thing that is, evidence-based, must include youth, minority inequalities, and so that will be at the foundation of all recommendations that are moving forward and in the director's office as they look through things. But I think that it's important for us to mention youth at this point. Dr. Wagner?
Thank you, Chair. Karla Wagner. I wanted to add a note to the scholarship fund bullet point, and we don't have to debate this now, and I know, but I would be interested in having it say something specifically about setting aside some of those funds for people who have been directly affected by the opioid epidemic. So I can see how we could create a workforce development fund that would fund people to go back to school, for example, to become licensed substance abuse counselors. And some of those people might be people who've been directly affected, and some of them might not be. But since what we're talking about is settlement dollars, I would like to somehow carve out some of those funds for people who in some way demonstrate that they themselves or their families or their community has been disproportionately affected. And I don't know how you implement that in real life, but maybe it's something we could talk about later and just note now.
Yeah, and I think that's awesome. That's a great point of view that we need to include. And again, we wordsmith as best we can. We pass it up, and the director's office will take that into consideration. But it's a huge point to add in there if there's going to be infrastructure created through educational opportunities, that we include people that were specifically part of the target population or affected somehow. Cornelius?
Thank you, Mr. Chair. Let's see, so I'm wondering how much of bed availability has to do with available personnel. And that was just sort of spoken to. So I actually don't know. I'm just curious about that. How much is an actual physical place to be, and how much has to do with people that are trained to work and man that, and that piece. And I think we're capturing that. I'm sorry for the background noise. I think we're capturing that. And then with regard to despite an individual's insurance status, are we trying to say ability to pay rather than insurance status, or are we saying insurance status? Does that make sense to folks, the distinction I'm making?
Right,
Well,
ability to pay.
yes, ability to pay, this is Elyse, but also the type of insurance somebody has can impact their ability
yeah.
to get care. So I do think it's something that we should address. And maybe that is a policy thing, but I think that ability to pay and type of insurance, you know, so I won't get into it, but yeah, it's something we should include. Thanks.
Elyse, this is Cornelius again. What I like about that inclusion is that it's been my experience as a clinician that coverages for different services differ broadly based on insurance provider. Even though there's mental health parity is supposed to be happening, there's parity, there's some coverage in almost every case, but it really differs depending on who the carrier is. It really can differ. And I think that's a policy question that needs to be looked at. So as this is language, I think it suggests that. So I appreciate that, Elyse. That's great.
So we have workforce infrastructure funding. And then the policy question, it seems we've attached it to, or brought it forward as part of the recommendation. And, you know, to speak on Cornelius, the first part of what you mentioned, in my understanding, it's, and how do we, okay, my understanding is that it's 50-50, you know, the facilities, we could use more of, the workforce we could use more of, but as facilities are able to increase, I think we're still finding a shortage of workforce. But
okay.
that again, hopefully is something that our recommendation moving forward to the director's office is not lost on them. I think that the information is available and they'll be somewhat in the know as far as what it is we speak of when we speak of infrastructure.
Mr. Chair, thank you. And Cornelius again, process suggestion to the committee that once we have these prioritized today, perhaps they come back out to all committee members as you know, some type of ranked questionnaire again, or like an up-down approve, disapprove, and people do that like we did with the survey questionnaire. That we don't do that process today. We just sort of tidy these up and consider them and discuss and then send out. I don't know how other people feel about that idea.
Yeah, I really like that idea. It will, overall what we're talking about is we fix them up, we remove what we need to, we get them ready as agreed upon as a good recommendation to move forward. And then not in this meeting do we vote on them, but we get a questionnaire to where we approve or deny each one of them. And then that will be used by Dawn and her team. That will be used by Dawn and her team to develop the report that will come back to us. Or actually, sorry, that'll be used before it goes to, it'll go to Mercer and the objective tool and then into the report. That does make sense though. Okay, so I don't know that if we are, we'll have to look into what it looks like to, yeah, I think it'll be okay. I don't know, Ms. Rasul, if you're here or available, but I guess what my question is that, is this committee allowed to make it concrete, make their recommendations concrete through a survey online that would then be sent to Mercer to go through their objective tool, which would then be put into our report? Or do we need to do that here in open meeting?
It has to be done in an open meeting.
Okay, thank you. So it looks like we will group them together at the end and then take a vote on them. So as we're going through them, I think we're not losing too much time by grouping. You know, we'll go through them, discuss them, edit them, and then at the end we'll approve them in chunks. And I think we're doing it basically by going through them. I believe we're ready to move on to the next bullet point, which is expand harm reduction services in both urban and rural it's 11:10. We've been here for 2 hours. I imagine in my head, I hope you guys have time that we have another 2 hours, especially if we can start to move forward, and I got a couple head nods or wags. So let's just take a quick restroom break or drink break or stretch break. We will take a break for 10 minutes. It is currently 11:10 a.m. We will regroup and start this meeting again at 11:20 a.m. We have a 10-minute break beginning now. Thank you.
Strike three.
All right, we are at 10 minutes, moving on to 11 minutes. When you return, if you could turn on your camera so that I'm can get a count of how many people are present and available so we can ensure we have quorum, I would appreciate it. And once I see that we have people's cameras turned on and we are able to move forward because we have quorum, we will continue. Right now, I see that we have 11 committee members present. If you were not here in the last couple of minutes, I'm just requesting that you have your camera on so that I can ensure that we have enough people here to continue moving forward and that we have quorum. For 3 more committee members that are here. There we go. So that we can continue moving forward, can I confirm that Brittney is back in the meeting from the break, Pauline is back in the meeting from the break, and Katherine is back in the meeting from the break? There we go. Missing 2, let me count. 1, 2, 3, 6, 7, 8, 9, 10, 11. All right, I see that we have 11. There we go, 12. All right, looks like Pauline is not with us, but we do have quorum, so we are going to continue forward. And we will move to the 5th bullet point, which is expand harm reduction services in both urban and rural underserved areas. This should include funding for syringe exchange, fentanyl test strips, and naloxone distribution. I'm sorry, I forgot to mention that while we were on break, I talked with Dawn, and we are going to use a, she's going to be sharing her screen with a PowerPoint presentation that has our, what we're looking to make sure that we cover our gaps and what it is we're supposed to be, how we're going to tie our recommendations to SB 390. And she has input the ones that we have agreed upon so far into their areas, and as we move through, this will kind of be the guiding document that helps us find a place for our recommendations as they concern SB 390. So again, I'm going to start with expand harm reduction services in both urban and rural underserved areas. This should include funding for syringe exchange, fentanyl test strips, and naloxone distribution. Does anyone have any comment or discussion for this bullet point as a recommendation from this committee? Dr. Wagner.
Hi, Karla Wagner. Can we see the earlier ones? I would like to see if we can align the language with the one that we wrote first about sustainable funding.
Yes.
So where's
I think we just need to switch pages and we'll have it. There we go.
Yeah, so how about sustainable investment in harm reduction programming to include blah, blah, blah.
Yep. Sorry.
I want to use the same language from this one.
Yeah, there we go.
To update the harm reduction one. Yes.
And I think you can almost cut and paste the 5th bullet point from the recommendations from ACRN page 1. There you go.
Sustainable investment in harm reduction services in rural and rural underserved areas, including but not limited to funding for syringe exchange, fentanyl test strips, and naloxone distribution.
That sounds really, really good. I think there it is. Both urban. I think if we reword, this should include to including, and what was the other? How did you say it?
Sustainable investment in harm reduction services in both urban and rural underserved areas, including but not limited to funding for.
Perfect.
Syringe exchange, fentanyl test strips, and naloxone. And my point there is, as Elyse mentioned earlier, at the moment we are concerned with fentanyl. At the moment, naloxone can help with our problem, but drug trends evolve. So I just don't want to constrain the funding to things that are a problem in this moment.
Agreed. Does anybody have any other discussion or comment on the updated bullet point 5 as far as a recommendation? I think it looks really good, and I'm not seeing up any hands or concerns. If you do have something that you would like to say and we move forward, you can just ask that we step backwards to relook at this one, and we will do that. As for now, we will move to bullet point number 6, which is support secondary prevention strategies, including screening and linkage to care, school-based mental health, and other community-wide multi-pronged strategies. Again, as we noticed on one of our other bullet points, some of these bullet points will be almost, as part of the foundation of what is expected, especially when we're considering evidence-based or through a lens of equity and equality. As we look at this one seems to focus on secondary prevention strategies. But I see the importance of screening and linkage to care. It also has ties to school-based mental health. Is there a way that we want to adjust this? Do we want to set this aside and see what comes up that can? Yes. So underneath the highlighted one, we have support secondary prevention strategies. Is there a way that we need to edit this, or what would we like to do with this? I think the order is set, but I'm not sure. Karissa, please, if you will.
Thank you, Chair. Karissa Loper. I'm wondering for this one, if we can word it or agree upon wording it, the mirror slightly the way we did the initial bullet, and perhaps focus the language on community-wide multi-pronged strategies and leave it broadly like that. Unless those other ones, we think we need specific, I think, recommendations related to the first 2 points, screening, linkage to care, and school-based mental health.
Thank you, Karissa. Can I get some support or comments on Karissa's comment?
So, Chair, if I could, this is Elyse. So I think this one actually might have been mine from the survey. And I am in support of aligning the language with kind of the first one that we did. But I would like to make sure that we are calling out kind of secondary prevention and linkage and screening as its own thing. Because, I just don't want what we've recommended for funding to be primary prevention and education and then harm reduction with not a lot in between for either youth or young adults or any adults that may initiate use after engaging with a prevention system that they then develop an issue or need for support. So in support of aligning it with the language around investments of evidence-based strategies for underserved geographic and demographic areas, but I would personally just like to make sure that we're holding out that secondary prevention as a need.
Chair, this is Karla Wagner, if I may. I feel like this one might be one that needs to get tied back a little bit more to the needs assessment. Like we all know secondary prevention is important, but where are the deficits that need to be filled? So I'm trying to look through the needs assessment right now, and I'm on page 48, where it seems to suggest that there's a little bit of talk about things like SBIRT in here. Although it is difficult to assess how much screening and referral is occurring in Nevada, Medicaid claims for SBIRT are very low, especially in managed care, indicating a likely underutilization of screening and referral. More screening for SUD would result in more individuals being referred to treatment. So I wonder if we can tie the action. Non-behavioral health providers, such as dentists and primary care providers, could benefit from more education on screening and referral. Lack of knowledge of benefits and treatment options has also been cited as a reason for not pursuing treatment. I mean, maybe it's, can it be, so can the recommendation be targeted a little bit more, Elyse? Does that?
So, I think what I was trying to get at with that recommendation is making sure that we're funding supports and programs for like, I guess youth specifically, that are like, I don't know a better way to say it, so I'm just going to say it, like far gone past like hearing that drugs are bad and may have initiated use and may need help getting connected to services. But first they need to be screened and then connected. You know, with a lot of the work that's happening now in the state is federally grant funded. We all know that. But a lot of those grant funds say things like primary prevention and, screening and linkage to care isn't primary prevention. So I just want to make sure that if there's, and we know that there's issues with youth initiating drug use earlier, that we're holding up resources for that kind of mid-level intervention. But I'll have to look back at the needs assessment to see if maybe I can tighten up the language a little bit, because I hear what you're saying.
And in the hopes of having these recommendations moved forward today, would it be feasible to use the first portion of this recommendation and at the point of and strategies including screenage and linkage to care, comma, take out school-based mental health and other community-wide multi-pronged strategies, but add in the target that we're looking for, which is youth. And I'm just trying to figure out a way to make this concrete. And
Chair, if I may, this is Karla Wagner. I think to tie it to the needs assessment more closely, we could say investment in increasing utilization of secondary prevention interventions and strategies for screening and linkage to care, focusing on, I mean, secondary prevention is focusing on people who are using and could benefit from treatment, right? So focusing on populations that are demonstrated to have low uptakes, such as Medicaid recipients and non-behavioral healthcare providers. I mean, what the needs assessment is saying, Medicaid claims for SBIRT are low, especially in managed care. So that is an area where this is not being used, but these people probably exist. And then utilization of SBIRT is low in non-behavioral health settings, such as dentists and primary care. So maybe so that's what I'm talking about in terms of targeted. And maybe to Elise's point, I mean, where else, other settings where you're going to identify youth in school-based or non-school-based settings.
So this is Elyse. Chair, if I could, I'll just say I am in complete support of what Dr. Wagner has said. That's kind of a lot to unpack. And I know that time is of the essence right now. So maybe, and I know this is being recorded, maybe staff can just go back as they're documenting from the meeting and take note of what she had said. But I'm in complete support with what she noted about targeting underserved areas.
Sustainable investment in increasing utilization of secondary prevention interventions. It's
For now,
something-
say underserved populations as noted in the needs assessment on page 48.
Wow, that's it right there. Oh, Katherine, sorry, please take the floor.
No, thank you. I was gonna ask if that could be more clearly defined, and she already answered that. And definitely mentioned that I wanted adolescents and youth included in that, which I think is the intention as well. So thanks.
Thank you. You know what? I didn't mention when we got back from our break that this PowerPoint has been filled with not only what we're meant to target in SB 390, but also the recommendations have kind of been sorted and placed into the categories that they would fit in SB 390. So instead of moving down from the initial document that had our recommendations from ACR1, page 1, page 2, page 3, page 4, I'm going to continue down the list as they have been inserted from that work into this PowerPoint. So moving forward, I believe we're all on the same page and comfortable with this last bullet point, and I would like to move to creation of more inpatient rehab facilities, which is kind of short and blunt. And do we have anything that we can add to or adjust this recommendation? Elyse.
Sorry, I couldn't get off mute. So I actually think that would fit nicely under the infrastructure recommendation we talked about earlier. So maybe that recommendation is an investment in investment in behavioral health or treatment infrastructure to include creation of more inpatient facilities.
Right, I think this one's kind of, I think we're gonna find a lot of them that are kind of crossover and mesh with each other. But I'm pretty sure I did this one and all I meant was the capital investment. At some point, it was my understanding that the funds or the recommendations towards funds that we could have some influence on would be as much to say as, you know, building or getting more physical locations in action towards supporting this population. So it looks like we have reworded this recommendation as investment in behavioral health infrastructure towards the creation of more inpatient rehabilitation facilities. And I know that this one is crossover as far as infrastructure, but I think that it wouldn't hurt unless somebody thinks that it doesn't need to be added, to add a comma after inpatient rehabilitation facilities, comma, and detox centers or detox facilities. So I think that both are capital projects that could be super helpful. I don't know, I feel like there's not enough detox facilities, but maybe there is and I'm just not knowing it. Does anybody have any comment or discussion for the current recommendation that we're on, or shall we move forward?
Chair, can I just, Karla Wagner for the record, can you just make the same sort of note as up above in areas demonstrated in the needs assessment to be lacking in this infrastructure or something, because then we can go back to the needs assessment just like we did for the one before and say, okay, here's what it says, right? Because we have our feelings, but we did actually fund this major document, and part of this needs to be going back and forth between them.
Yeah. Agreed. Perfect.
Thank you.
And it shows where there is, you know, where they are and where they're not. So that's perfect. That's exactly what thank you for adding that. As we add that, it looks like this one is done and we can move on to the next one, which is peer support workers along with community health workers implanted in the recovery support programs across the state. Do we have any discussion on this one or rewording that, or how do we feel about this recommendation? Dr. Wagner.
I know there are people, or there were, I don't know if I see her anymore. I know there are people on the committee who work for these peer programs, but again, maybe my overarching recommendation is to kind of use this same language, sustainable investment, because one of the concerns with the peer programs as they're run right now is that they're mostly grant funded. And I'm sure there is somebody on the call who can speak to this better than I can, but I don't think they pay sufficiently to allow people to have this as a sustainable career. So what this money could do in terms of peer programs is supplement the grant funding, create sustainability, and pay people enough money that they can stay in this job. But I completely defer to somebody else on the call who has more expertise in this than I do.
Yes, thank you, Dr. Wagner. And before I move to Elyse, I'd just like to say that it, in my experience, is mostly an entry-level position into behavioral health, and it's kind of guided by lived experience, which is awesome. I think that this specifically having community health workers and peer support workers in the recovery programs across the state could be an effective tool towards destigmatization as well. You know, having lived experience and being implanted in hospitals, schools, the judicial system, anywhere where we find somebody who has experience with substance misuse or opioid use disorder, there's a place for them. Currently, we see them in treatment facilities, whether it's inpatient or outpatient, but I also think there's a place for them in social services, hospitals, judicial systems, school services, all of the above, because we find these people, this population is, you know, across the community.
Thank you very much for that. And so to that end, I would suggest another amendment to the language to that they are not just implanted in recovery support programs, but broadly across social services. And there are initiatives towards that end in Washoe County already. And I would really like this to say something about paying people a livable wage. I don't know if that's, I don't know if we can go that far, but like these cannot, in my humble opinion, these cannot be considered volunteer positions that people do as service along the way towards some other job. We have decided, and the evidence shows us, that these are important jobs, and these jobs have an important role in substance use and behavioral health and harm reduction. And so we should, as you said earlier, invest some capital in that.
Yes, and you're right, Elyse and Cornelius, I will call you, I promise. The evidence shows that the benefits of utilizing these programs or these workers in behavioral health settings is they pay for themselves. You know, they really do a great job of that. So I don't know what it would look like to add, and it may have been added while we were speaking, but including livable wages, to include something of the sort of, you know, where they exist, add something funding wise that would support them of staying there, or where they don't exist, starting them at a livable wage. But Elyse, please take the floor.
Thank you, Elyse Monroy, for the record. So just to acknowledge that, and maybe for the record, that there may be a policy component to this. I think the peer reimbursement rates are, I'm not sure if, I mean, they're established, the reimbursement rates are, I'm not sure if it's by Medicaid or some other funding source, but we may want to ensure that the reimbursement rates are, I'm not sure if the language is the livable wage or if there's some different way to say it, but there could be a policy component there. If maybe the policy, like reimbursement rates for whatever reason, Medicaid caps or whatever, can't be increased, then maybe these funds be used to supplement whatever reimbursement rates are set at.
May I, this is Karla Wagner, may I just follow up on that? Because I think we have some experts in this on the call, but I think from my perspective, doing the research that I do with some of these peer programs, part of the concern is that it's mostly based on reimbursement. And I 100% agree with Elyse that we need to look at the reimbursement side, but I think there needs to be money to pay for peer services in the absence of a reimbursable framework, right? If it's only reimbursable work, that limits the scope of what peer workers can do. But if we could pay people salary that's not reimbursement based, it could expand the scope of their services in important and meaningful ways. So maybe both. I agree with Elyse that there's a policy issue here and there's a funding issue.
Thank you, Dr. Wagner. Thank you, Elyse. Before I call on Cornelius, I'd like to say that, you know, these are, in my experience, and I'm a huge advocate for peers and community health workers. I am both, but still, I would like it to be somehow acknowledged that these positions are entry level. You know what I mean? They shouldn't be equal to what someone who. It's just hard to bump it up too much without it being too much, but also maintaining the workforce and keeping them there. So it's a delicate subject that is going to have to be figured out somewhere, but I don't know how much this committee can have sway or influence on that. Cornelius?
Mr. Chair, my comment ties into yours. And first of all, really appreciate your thoughtful comments about the destigmatization potential for these peer support programs. I know they've been really successful up here in Washoe County. One suggestion I have regarding this point is that we define what a peer support person or program is. And I think that might, so maybe there's a training that meets a certification standard or something like that.
There's a state certification. So
There
you
is.
could just say it like that.
Okay, so maybe we fund some, is there training that they pay for? Pardon me, for that, to become a certified peer support specialist? Do they pay out of pocket for that training?
My experience has been that it depends on the organization. Most organizations will pay for it, but specifically the peer support training is around $100 in the north. I don't know if it's statewide. I guess it is statewide. And it's, I would say, not too evenly distributed where it's pay out of pocket for $100 or the organization will pay for it. But I think that our language around this and our concern or like how meaningful we find this recommendation is an important one, is looking good on what we have so far. And I would advocate for this committee to continue working through the list unless there's something that we see that is off in the verbiage or that we would like to include or remove. Cornelius, I didn't mean to cut you off and I appreciate you.
You didn't at all. No, thank you, Mr. Chair. That helped clarify just around the discussion of livable wages and the distinction maybe of entry level versus a more highly trained person and well, you know, I just thought it might address that concern. I'm not finding the language for it, but I understand now. So thanks so much. That helps.
Yes,
and I'm done with my that's my consideration. So thanks.
Thank you so much, Cornelius. And yes, to be clear and sure, that it is important to make sure that we have some type of body overseeing the certification of peer support workers and community health workers, and it exists and it seems to be functioning pretty well. We seem to be moving forward, but there's always more that we can do, in my opinion. Elyse, did you want to comment or is your hand back down?
No, the only thing I'll say, I've just been kind of noodling on what Dr. Wagner said about the scope of peers. My program that I work on, we employ a peer, someone with lived experience, and he provides just great insight into how we develop our program. So I see the benefit. But I just want to make sure that I mean, peers alongside community health workers, that's the role of peers in the health and social support system. I think maybe what Dr. Wagner might be getting at goes beyond that, is more of a recovery friendly workplace initiative or something like that. So maybe just something to noodle. Maybe there's a recommendation for expanding the role and scope of how peers work in the community and the types of like places in the community that they work or something like that. I'm running out of my wordsmithing steam here. We've been at it for a while.
Yes, and that's why I want to keep moving us forward, which I really appreciate you bringing that to light and it and highlighting Dr. Wagner's point. But I think that if we look at it one more time, investment in peer support programs along with community health workers implanted in recovery support programs across behavioral health and social services, including review of reimbursement. I think it's on point. I think we're the recommendation is can be taken by the director's office and put forward and see what that looks like. But I think it meets what this committee's goals are aiming towards. If there is no more comment or discussion on this specific recommendation, I would like to move to the next one. The next recommendation that we have is the expansion of payment coverage for family treatments, insurance coverage for family-based treatments lags individual treatment, creating a disincentive for many providers. Family, caregiver kin-based programs to fortify adolescent and young adult attachment as a preventative measure, providing training in administration of family-based treatment. So it would start with.
I'm sorry, pardon me, Mr. Chair.
No, please, go ahead.
This is Cornelius. That clunker was mine. And it was trying to get a whole bunch in the short scope of the form that we filled out.
Yeah.
And so what I'm trying to say there is it's been my experience, and there's a lot of research behind it as well, that if we can make interventions at a family level, and especially from an attachment perspective, and fortify young people's sense of attachment security, we can have a preventive effect regarding bad substance abuse outcomes, including addiction and the consequences of addiction. And also what I'm saying here is that there's a disincentive to providers like myself out in the community to provide family-based treatments, because insurers reimburse disproportionately for individual versus family psychotherapy in almost all cases. And usually it's been my experience, it's about family therapies reimbursed at about 2/3 to 3/4 the rate that individual psychotherapy is. And so I've been advocating that insurers who provide in Nevada should have to provide for co-joint therapy. So parent and child, parents together with kids, siblings, they should have to reimburse that at the same rate they would individual psychotherapy. I just think it's a way more effective way to work with young people from a preventive and treatment, of active problems basis. It's well established in a lot of different areas of therapy. So that's what I hope that makes sense to the committee. That's what I'm saying. And I expanded with caregiver and kin, because of course it's not always just parents. And also we need to train providers we have to have money up for providers of family-based therapy. A lot of people can't attend trainings. A lot of therapists, younger therapists that are starting out, with the cost of rents and other things that are imposing on them, they can't throw down anywhere between $500 and $1,000 for high quality training. And I think that'd be a phenomenal investment. Might start in the schools, but anyway, sorry guys, I know that's a long-winded chunk there, but reimbursement equity is part one. And the other part is training and investment in training. I'd have to actually rework the wording. I didn't anticipate this being presented this way. I could tidy that up, but like Elyse, my steam, my wordsmithing is falling aside.
Yes, thank you so much, Cornelius. And yes, it is a mouthful, but it does overlaps with every one of our perspectives that we bring to this group. It's and directly your experience, and the wordsmithing is going to be a challenge. We have someone working on it now, but the intent and purpose is dead on when you bring to light the reimbursement portion and the training portion. But what I'm seeing when I look at this one is the experience of families as they go through services connected to their school because of substance use disorder or behavioral health issues, or treatment in general, whether it's directed by Child and Family Services, some type of judicial system, or just sought out on their own. We need to find a way to help supplement those existing organizations or programs to get people to be able to maintain working with therapy if there is such a discrepancy between the reimbursement between a family therapist or setting and a individual therapy setting. But also my understanding of the situation is that there seems to be this, when you talked about attachment, there seems to be this challenge between going through the system, whether that's the school system, Child and Family Services, the judicial system, or having mental health issues or substance use issues in general, that the stigmatization and the uncertainty and crappy feelings around having to go through that system really doesn't keep people bound together. It kind of separates them, especially when we have that financial hardship attached to it. Dr. Kamyar, and then I have Brittney. Dr. Kamyar?
Yeah, Farzad here. I have to drop off in a few minutes at 12, but to sort of, I think I finally figured out what was going on. This is sort of echoing what Cornelius had just mentioned, was like, I didn't realize that this is what's going to be here. So I looked at the survey, and the survey pretty much, this is what happened. You had an area where it identified all the gaps, as just as titles: prevention gaps, treatment gaps, discharge and recovery support gaps, and we had to order those and prioritize them, right? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then there was, please list, based on these gaps, what is our recommendations you would like to see? There's a little text box. And then 7 says, based on the stuff you put up above, select all the recommendations that fit best, right? And that's where we would select the SB 390, right? There's no actually tying them. And additionally, I didn't realize that this is what's going to be like our formal recommendations, because now I'm looking at all the treatment gaps, which is where we were supposed to sort of prioritize, and it's in that document that you guys are looking at. And there's a lot of really good stuff. I mean, there are a whole host of recommendations that I would like to put in, right? There's the data gaps, all the stuff. Yep, every one of those. Prevention, yep, I want those as recommendations. Treatment, yep, I want those. I mean, this is where I'm saying I was under the impression that for each of these gaps, basically, that was identified by Mercer and the years and years of data that they have all, like Dr. Woodard had mentioned, had put together, there's a lot of good stuff here. And I don't think that maybe the 20 or so recommendations we've submitted has done it justice to talk about every single one of those. So I guess before I leave, if I need to email and just say, yep, every single one of these points we should consider under the treatment gaps, and then tie those to the SB 390, that's sort of where I stand.
Yes, thank you, Dr. Kamyar. And
like Chair, right? I mean, we haven't even talked about really treatment yet, all the gaps in treatment. There's inpatient treatment, there's residential treatment, there's outpatient treatment, there's all the secondary prevention stuff with like SBIRT, and there's special populations that need to be considered. Yeah, we might have touched on them with some of the points, but it's pretty comprehensive, right? To go through all of those. And again, I apologize for having to drop off. I just thought we would be going till noon. But I think really important that we get to these in addition to all the points that everyone has listed, that you guys, I guess, will go through and continue to go through.
Yes, and thank you for speaking before you take off, Dr. Kamyar. I appreciate it. And you're right, there's, as I look through the recommendations that we have on these 4 pages, not once do we mention incidence and severity of neonatal abstinence syndrome. So there's a ton of what has been found as a gap in the Mercer reports that we do not have a recommendation for at this point. And
right. Yeah. So what I was trying to quickly do is go through like the 4 or 5 pages of recommendations and tie them back to the SB 390. I'm not seeing anything about evaluation. I'm not seeing anything about implementing the hotline. programs of persons involved, service of like all the crisis stuff, prevention and treatment of infectious diseases. Because I don't know that from the survey, what we were putting in that text box was supposed to be the sum total of, hey, here, state of Nevada, here's our recommendations that we've put together. I will say from my perspective, I assumed that the Mercer work that had been done to identify all the gaps would eventually make its way into some sort of recommendation.
And I think that that was the intent, is that the Mercer presentations were meant to guide our recommendations through the survey, and as we meet today, to kind of fill in what gaps Mercer has identified and what our recommendations are for those gaps. Again, we are not the only entity providing recommendations to the state, and there is some work to be done as far as what we have so far listed as recommendations and what we can add to it. But time has been a super sensitive issue, and I think that we're doing pretty good moving forward and nailing down some things. It's looking like we can keep moving forward, but what the next meeting is going to look like is will kind of be determined off of what we get done today. Dr. Kamyar, did you want to add anything before you take off, or can I call on Brittney?
No, as far as awesome. Thanks you guys for doing this.
Hey, thank you for being here. And again, I'd just like to add that in between meetings, this committee has generally met for 1 hour or 2 hours. Today we're meeting for a little bit longer, but in between meetings, if you're able to kind of go over the information that has been provided and do a little bit of homework to kind of stay up to date on and really for me, it's like getting my head around what our goal is and what we're going to be doing at the next meeting, and how I'm either educated or missing some information about how I'm going to make decisions or make my recommendations. But we are still working on recommendations with Mercer as well. So what we have here and what we are doing, we will also be supplemented with the gaps that we have helped Mercer to identify, and we will be getting the recommendations based off of what we talked to them about from them as well. So I don't think that we're going to see a place where we completely ignore some of the gaps, but what we have right now, as far as we've submitted, these are our recommendations, that's what we're going over, and we will see more of what those or what other recommendations look like as we have worked with Mercer. Brittney?
So mine is just very simple. For the one creating interventions at a family level, can we also include that transitional age group of 18 to 25 as well? Because I still think that they need the support of the family instead of just including, children, youth, and adolescent. I think it's also important to include that transitional age as well. So.
Yes, I think that's excellent point. Thank you so much. Yeah, including they're not just non-existent support group once they transition from 18 to 25, right? They still have their support group, whether or not that's family or not, but having that at least available rather than limiting it to you're an adult now, so you're not part of that family as far as treatment and service goes. Cornelius, did you have your hand up?
I did really quickly, Mr. Chair. And Brittney, thanks so much. That was part of my intent. And this as well, the young adult recovery program in the Washoe, I forget which court, I'm sorry. It's in a Reno court. I think it's Department 2. It's really, really an interesting program, and it covers up to, I believe, age 26. So it's a super important point that it's also young adult. I also have to drop off the call. I blocked out 3 hours, and I've got someone waiting on me, and so much appreciate being a part of the process with everybody today. Thank you all, and I look forward to rejoining you. I'm sorry I have to leave the call.
Okay, thank you, Cornelius. I'm trying to get some clarification right now to find out if we have to end this meeting because of open meeting law, or if we're allowed to continue as long as we have quorum. Ariana, did you have your hand up? Oh, I think you're on mute, but I see you talking, but it doesn't look muted, but I couldn't hear you.
Sorry, can you hear me now?
Yes, I got you.
Okay, yeah, sorry. I have to drop off too, so I just wanted to make sure you knew to consider for quorum. If you are still meeting, I can come back, but I have to take a meeting right now, so.
Chair, may I
Yes.
suggest that you take a motion to move the recommendations that you guys have worked on forward into prioritization before we lose quorum?
Yes, thank you, Don. As Don stated, we may lose quorum here and we're not sure about the timing, but right now we have come up with a handful of recommendations that we have gone through and agreed upon. At this time, I would like to see if there's anybody who would like to make a motion to move these recommendations that we have wordsmithed and agreed upon forward for prioritization through the Mercer objective tool.
This is Elyse. I'll make the motion to move forward the recommendations that we've worked on and wordsmithed for the committee to move forward.
Do I have a second?
And this is Pauline, I'll second.
Thank you, Pauline. All in favor of moving the recommendations that we have worked on and edited and agreed upon forward to get to Mercer for the prioritization through their objective tool. All in favor, can I get an aye, please?
Aye.
Aye. Aye.
All opposed, can I get a nay, please? And do we have any abstentions? It looks like this committee is in favor of moving the motion and moving these recommendations forward to Mercer to be put through their objective tool. Thank you, Cornelius, for joining us and giving us your time. And committee, if you can give me a second, I'm going to find out if we have quorum and if we're going to continue. It looks as though we continue to have quorum with those that have left. And as such, I would like to move forward with the next recommendation to go over it and see if we want to approve it. It is approaching the problem from an 80-20 perspective. Limited resources, so prioritizing what will save the most amount of lives versus treatment with MOUD and everything that is tied to treatment, evidence-based informed practices across all treatment in Nevada. So this one, I'm sure has a specific intent, but I believe this is from Dr. Kamyar and he's not here. As far as the back end of the recommendation, we are going with the premise that any recommendation that we put forward will be based on evidence-based and informed evidence-informed practices. So how we can use that language and tie it to a recommendation will be kind of a challenge. I don't know if this is one that we need to necessarily move forward as a recommendation, but more as something that we should keep in mind as we work through the recommendations. Does anyone have any discussion or comment on this one?
Chair, this is Karissa. My comment here is, I think to say Dr. Kamyar's point again, is if we do want to have a—
I'm sorry to interrupt, Chair. Can we take a minute and make sure we have quorum? We're only counting 8.
Yes, sorry about that, Karissa. Let's confirm that we have quorum. I'm going to bring up the participants and we will do a quick roll call. It looks accurate. Joan, can you help me figure out how to check quorum at this time?
Jessica Barlow has left. Brittney's still here. Lilnetra is still here. I don't see Ryan.
6, 7, 8. I see
Dr.
8.
Kamyar is not here. Karissa is still here. Yeah, I'm not counting because we had 2 absentees to begin with, it looks like we lost 2, 3, 4, 5, 6, 7. Yeah, I'm only counting 8. And you
All
need
right.
9 for quorum.
Because we no longer have quorum, I believe that we'll have to end this meeting here and adjourn.
Well, first you have to address public comment real quickly.
Yeah, and before I do that, I wanted to move to agenda item number 6, which is the notice of the date for the next ACRN meeting that will be held on June 8th. And there should be a public posting, as well as each panelist should receive an email giving them their link to enter the meeting as a panelist. And I will move to agenda item number 7, which is public comment number 2. Do we have anybody from the public that would like to make public comment?
Chair, before you move on, this is Karla Wagner. Can I ask, it seems like we're having some scheduling trouble because people don't know how long to anticipate being in the meeting. So we know that the meeting is on the 8th, but can you just let us know how long people should dedicate so that they schedule properly?
I think that I'll have to work with the facilitation team from the state and Dawn and Joan and her team to find out what it is or how it is we're going to navigate these next 2 meetings, being that we have quite a bit of work to do left, and we were trying to meet a deadline of, I believe, June 31st or maybe July 31st. So I think it would just be at least adequate enough to say that for the next meeting, we set aside the same amount of time, which is 3 hours. Is that something that this committee got a lot of probably not faces on there?
Chair, it's Karissa. I like, just based on this today, I think you need to try and get us to commit to a 5-hour period. Like at least 4, I would say, because we're obviously 3 hours in and weren't able to get through our recommendation.
Yeah, I would love that. I just don't know how many we can get.
Because if you get us to commit, that means we have to find we've got to find the slot to take the time to do this. We all committed to this committee. We just need to know how much time.
Okay.
I agree with that. This is Elyse. Yeah, I agree. And I know 5 hours seems like a lot of time to ask, but I think the actual deadline is June 31st.
Right.
So it's like we're just kind of pushing towards the end of this phase. So 5 hours seems like a lot, but I think we need to do that.
And I guess this conversation will be in the minutes. So I would ask that the next meeting to be held on June 8th will be scheduled for 5 hours in the open meeting notice, and also sent to each panelist with their individual invitation to set the meeting for 5 hours, and to have each committee member commit to being there for 5 hours. If we can maintain quorum throughout the meeting, we can get some real work done.
You might have a little bit of a, you might have to schedule that with people though.
I know, right?
Meetings are kind of showing up on my calendar, and I try to move things around, but I mean, I know we have clinicians on the call. People can't always make a block like that without consulting their schedules first.
And this is Brittney. I definitely agree with that. And I think it's asking, especially depending on, I'm a clinician. So depending on what clients I have, I might not be able to move them around depending on their schedule. And it might not also be in their best interest to not see them that week either, depending on the situation. So I'm not opposed to doing more meetings. I don't know if I can block out 5 hours.
I am open to suggestions on, okay, so we already have the 8th scheduled for 3 hours. I guess, I don't know if that's negotiable. I don't know if we can add time to that or not, but if we can, we should try and see if we can maintain quorum. If we can't, maybe we try to insert another meeting before, what is it, the 8th and the 18th is what we have so far. Maybe we try to sneak in another meeting.
Chair, this is Karla Wagner. I think that's exactly what I would suggest, is that you poll the members to see if you can get people to stay longer on the 8th. since people already have the 8th blocked, maybe
Mhm.
you can assess people's availability to see if we can extend that meeting, and then maybe schedule another one based on people's availability. I
Yeah.
guess I'm just suggesting scheduling based on availability rather than kind of dropping a meeting on
Throwing
calendar.
it in there.
I have lots of flexibility, but other people may not.
Right. Okay, so that's a great idea. So right now we'll keep the meeting for the 8th for 3 hours, and then we have the meeting on the 15th. I'm sorry, I said the 18th, but it's the 15th. And moving forward, we will get an invitation, or sorry, a doodle poll sent out today that will try to gather the committee members' open schedule and availability to see if we can fit in another meeting.
David, I didn't cancel the meeting on the 15th yet because I thought it would be too confusing to send it out before today's meeting. So actually on the calendar with calendar invites, you already have meetings scheduled on the 8th, the 15th, and the 22nd.
We could get some work done there. Do we still want to send out a doodle poll to confirm that people will be there for those meetings and see if something else will work? I think we ought to do that, at least confirm that the meetings that we have currently on the schedule, that people will be able to attend to determine if we will have quorum during those meetings.
Okay.
So I think the best we can do from here is to ask the committee members to expect emails asking about confirmation for meeting times, and then respond with your open availability and how long you'll be able to be at each one of the meetings, so that we can kind of get a picture of how much work we'll be able to do with the meetings that we have left before our deadline. That being said, I really appreciate this committee's support in helping me navigate through this long and intensive a meeting, and also in planning for the next couple of meetings, and just having consideration for the fact that we really do have a lot to get done, and it will take hours and effort to get this work done. At this time, I'd like to open the meeting to public comment number 2, which is agenda item number 7. Just want to ensure that we don't miss anybody from public comment, and I'd also like to add a reminder that we'd like to avoid repetition and limit our comments to no longer than 3 minutes. Is there anybody available for public comment number 2? I have one person. I'm trying to pull it up. Give me 1 second. I can do this. Participants, attendees. I have Katherine Saunders. It looks like, oh, there you are. Here, the floor is yours, Ms. Saunders. There you go. We can hear you, but it's really muffled and muted. There we go.
Is it a little bit better?
We had you. Okay.
Okay. Yes, I just want to know, I'll go forward over my recommendations. I was just in the process of moving this past week, and so I'm a little bit behind on my business documentation, but I just wanted to let you guys know that I'm still involved and will be forwarding that over shortly. So I appreciate everyone's time today as well.
Great, thank you, Ms. Saunders. We appreciate you, and please send that email out so that we can include the public recommendations as well. Do we have anybody else interested in speaking as part of public comment number 2 before we adjourn this meeting? I don't see any hands up or any notices in the comments. Getting one now. All right. If there is no one else that would like to speak as part of public comment number 2, I would like to move to agenda item number 8. And before I do, I'm getting one more message. I'll just confirm that I'm not missing anything. Sorry about that, committee. Bear with me for just a moment. Okay, agenda item number 8, this meeting is adjourned. We will have the minutes for this meeting posted on our website. And if you have any comments to add to this meeting, please email it to the email address attached to this agenda. Thank you, committee, for meeting with us, and thank you for your work and commitment to this group.
Thank you.
We'll see you soon.